Okay. Good evening, everyone. I can see that our facilitator has joined. I will hand over to you. Thank you so much.
Hello, everyone. Hello, sir. Good day. And let me just bring my slide forward. Sorry, just trying to. Yeah. All right. Good day, everyone, and welcome to today's sections on our acute care physio essential. So, firstly, I want to thank the registrar of the board and for this opportunity, and again, the organizing committee as well, for the job they are currently doing with us for Nigerian physio as a whole. Um, so, just trying to sort out my slide. Sorry, can you see my slide, please?
We can see your slide, but it's looking small. Aha, good. Wonderful.
Yeah.
That's much better.
Okay,
That's very good.
perfect. All right. So let's get started. First of all, I want to assume that everyone has done some clinical reflections on the discussion we had the last time. If you have not done that, please kindly do that, because these are culture we need to be promoting in our workplaces. It's a very good way of establishing what you've learned as well. So, and again, feedbacks. I am very big on feedback. So of course I got some couple of feedbacks on our WhatsApp. Some people that know me in person, some people enter my DM. So there are a lot of feedbacks from what we did last time. Some people talked about, of course, someone mentioned about pacing of the teaching, which I think is very, very important. And I also appreciate that. And of course, we need to also thank the organizing committee as well for, putting, recording stuff down for us. We can go back to it, watch those videos 25, 7 times for us, for those informations to stick to us. And aside from that as well, some people mentioned to us about, to me about, some patients that are not being seen, probably because of our knowledge, or because of our skill sets. We're trying to avoid them and all of those things. So I think what is very, very important is just constant auditing of our service, to continue to meet the needs of our patients, because acute setting is very, very dynamic. We've got lot to do as a physios, and we've got a lot of patient group to be seen as well. And again, people mention about curriculum, why some of these things are not being taught in our institutions, even at DPT level. So honestly, we need to audit our practice, and we need to see how we can bring down some of these things, even down to the uni level as well. All right, so today, of course, I remain myself, Sherifdeen Olagoke. So today we're going to talk about oxygen, and then if we've got the time, we're going to talk about ABG blood gases as well, because it's very important. So the objectives, why are we here today, is just to give us some practical information about the use of oxygen, about what we need to know if we need to be handling oxygens, patients that are on oxygens, what are the hazards related with it, what are the signs we can see when patients are acutely deteriorating. And we're also going to talk about the policy. Of course, our registrar is here, so because there are a lot of policies regarding the use of oxygen. So we're going to talk about all of these things. And if we have the time, like I mentioned, we're going to talk about ABGs, blood gas. First of all, first thing I want to hammer here is that this is a road to safety. Safety, safety, safety. Because in acute settings, you're going to get a lot of patients that are acutely deteriorating, that are acutely unwell, that are being poorly on bed, that are needing oxygen to survive. So we need to know a lot of basics regarding the use of oxygen. And again, we generally do not want staffs, irrespective of your level of educations, to be handling things like this if you are not competent. Of course, I think one thing that I also mentioned here is, again, we need to also get ourselves to be able to design some competency that we need to be signing on our clinic. For example, now, this is one of them. Before any staff, before any staff should be allowed to handle these oxygen, and of course, you need to sign competencies. You need to demonstrate some level of knowledge. You need to demonstrate some level of skills when it comes to handling of oxygen. So I think it's something that we also need to start looking at, how we can build, how we can design those competencies, how we can get people to sign people up for those competencies. So this is one of them. So and again, I also mentioned this at the end of the training today. This is not to show that, of course, you're going to learn a lot of things, but believe me, these are just theoretical knowledge. These are just stuff that will be, that can facilitate our clinical reasonings. But that is not to tell us that now we have 100% knowledge about oxygen. Let's go on the road. Somebody is on 75% of oxygen, 80%, 85%. These are huge oxygen. I'm speaking now. I want to believe everyone is nobody's is currently on respiratory distress. We are breathing on room here. We are currently using 21% of oxygen. Imagine somebody now needing 80%. That's the huge. So we've not really. So everything we'll be doing today is just the theoretical knowledge. So there must be practical knowledge. There must be you demonstrating that you can handle oxygen before you go onto the ward to start handling patients that are on oxygen. That is the message I'm trying to pass here. So that is that. That being said, so let's get started. So oxygen. So like I mentioned, I want to assume we are all on room here. We are all doing our normal breathing, tidal breathing, relaxed breathing. Nobody's on any distress. You are not pursuing somebody. Somebody is not chasing you. We are not on football pitch now. We are all settling down, relax, and so I want to assume everyone is just, breathing on room here. That's 21% oxygen. Yeah, and again, from our general knowledge, we know these are colorless gas, they are odorless, of course, they are tasteless. So, and again, this is a drug. So this is a drug now that we want to be handling as a physios. And what that means is there must be a prescriber for that drug. Aside from that, so we're going to learn, are we going to be prescribing, or is there somebody that needs to be prescribing in case of emergency? What do we do? We're going to learn that. And aside from that, again, there are two measures we can use generally to measure, to check the level of oxygen that we've got in our body. One of them is checking their oxygen saturation. That probe you normally pop on the finger of the patient. You can use that to check. But if you are using probe, what that shows is what we call oxygen, what do you call it? Pulse oximeter. If you pop that on the finger of your patient, what that shows is just the amount of oxygen they've got on their hemoglobin. We know what hemoglobin is now from our previous teaching. So, and again, I can also do their blood gas. I can do their ABGs. ABGs will tell the amount of oxygen they've got in their plasma. So what's the difference between the two? We're going to look into that. And aside from that, everything we need to be doing as a physio regarding oxygen handling. So everything needs to be documented clearly and perfectly well. So if you are changing the tube, if you are getting the patient, if you are escalating them onto another oxygen device, if you are weaning them, if you are titrating them, all of these things must be in your clinical documentation. It has to go in the patient notes. You have to document everything perfectly well. All right. Sorry, can you hear me? Are we still there?
Hello?
Yes, sir.
Perfect. Let's crack on. So
Yes, sir.
yeah, thank you very much. So let's talk about indication for oxygen. So what are the indications for oxygen? It's just one big indication, which is hypoxemia. Hypoxemia. What is hypoxemia? Just low concentrations of oxygen in your blood. That's hypoxemia. So now, Breathlessness, no, no, no. Breathlessness is not an indication for oxygen. I know this can be very somehow. I know if you are very familiar in acute environment, you believe me. When you go see some patient, they are shortness, they are very, really, really very short of breath. And when you check their SAT is fine. But these are patients that will mention to you, oh, I need oxygen, please. I'm struggling to breathe. I'm feeling ear hunger. Get me on oxygen. Get me on oxygen. Yeah. Does that mean we need to be doing that as a physio? The answer is no, because if there is no sign of drop in oxygen in your blood and you continue and you pop somebody on oxygen, what you are doing to them is you are not doing an harm-free care for that particular patient. You might even be getting them worse than where they are. I give you a good example. There's something we call a rebound hypoxemia. Rebound hypoxemia means that, for example, now let's say before somebody used to be on, let's say their oxygen saturation used to be, let's say 95, for example, now, and when, let's say for no reasons, for any reasons, they now start getting breathless, start getting shortness of breath, and you now pop them on oxygen. So by the time you pop them, it might even be more difficult for us to win down the oxygen on them. So these are trainings that we need to be doing. I've done several trainings for nursing staff on the ward regarding anxieties in breathing, oxygen and breathlessness. So generally speaking, if a patient is breathless, if they've got breathing sensations, different types, I'm not going to talk about breathlessness here, and there is no sign for hypoxemia, generally there is no indication for oxygen. Even if they are requesting for it, then this is where you need to bring your physio skills. What do they need at that moment? Do they need reassurance? Do you just need to acknowledge them? There's something we call just a brief on breathlessness. There's something there is a model called breathing, what is it again? BTF model. That is oh my god, it's not coming. That is breathing function model. So what that model talks about is for example, now the breathing part, it might be maybe they've got some chest infections, they've got some chest concern, or all those things are there. The function part, it could be like maybe their breathlessness is coming from something else. Maybe they are being weak in bed. It could even be from the oxygen. Remember your urea, creatinines, and all of those things. It could be maybe that is what is driving their breathlessness at the moment. It could be reduced exercise tolerance at the moment. So the other part is just the psychological part of it. It could be psychological as well. Imagine somebody that is maybe they are being panicked, they are being anxious at the moment. They could also be short of breath at the moment. So what do you want to do with those patients? Just reassurance and all of those things could also help them in that particular situation rather than popping them on oxygen. Because when you pop them on oxygen, when you blast them on too much of oxygen, it might really, really make it difficult for us to win them on that oxygen. And if imagine now, patient that is meant to have been discharged, to have left the hospital now, because now we are struggling to win them on oxygen, what are we doing to them? We are making them to be prone to another infection in the hospital-acquired infection, hospital nosocomial infection, hospital-acquired pneumonia, and all of those things. And again, you are unnecessarily increasing their length of stay in the hospital. What does that mean again? You are wasting their own money. You are wasting the hospital's hospital resources as well. So that's that. So remember that's what you need to take away from here. And aside from that, again, clinical reasoning part of it. Imagine you've got a patient on end of life. What does end of life mean to us as a physio? It means generally the medical teams are not doing anything actively for that patient. Yeah, it's not on any active treatment. So generally, end of life patient is just no physio as well, no physios. Usually, you don't even get involved because generally, of course, if medical team are withdrawing their treatment, you should also be withdrawing your treatment. So in that regard, we are prioritizing their comfort. So in that regard, it could be now they are being short of breath, they have perceived dyspneas and all of those things. So oxygen, giving them oxygen in that regard is just to make things easy for them. So we are not doing active physios. Of course, no doctor will be setting target SAT for them in that regard. So we are not concerned if you blast them on oxygen. Yeah, comfort. We are doing everything for our patients. Patient-centered care. Remember that. So that's that about that. That is the indication. So we move down to another thing. What are the signs and symptoms of hypoxemia? Because first thing we need to learn here is how do we identify if a patient is DSAT? How do we identify that? I think the first thing here is decreased saturations. If the saturations is dropping. Of course, when you probe your oxygen, what do you call it again? Pulse oximeter, you pop them on the probe. So you can actually read their the oxygen in their hemoglobin, the saturation of oxygen on their hemoglobin. And again, some other clinical signs you can see is now their respiratory can start going high, their accessory muscles of breathing can start kicking in, all these neck muscles, all those things, sternocleidomastoid, all those things can start kicking in as well. Their work of breathing will start going high. Some might be drowsy at the moment, yeah, depending. Some can be, confused, agitated. Some can be, cyanosed as well. When you look at their fingers, peripheral cyanosed, their fingers, their toes, their central one. When you check their lips, their tongue, there can be purple, blue discolorations, all those kind of things. And what does that mean? If somebody now is getting, like their tongue is getting discolorated, it might be now there is tissue damage. Their cells are now struggling with oxygen. So you need to intervene. You need to do something as a physio. If that is your patient, you need to escalate to the medical team, and you need to do something immediately as a physio. So that is that about that. And again, just another few things here, of course, just to tell us how oxygen is very important. If the arterial oxygen drops below 4.3, they might go into coma. And for DELT, anything less than 2.7, the person is not compatible with life again. So that's it. So we don't want to mess with oxygen. Oxygen is very, very important. It's very vital. All right. Let's talk about the contraindication first of all before we so for contraindication, of course, if somebody is not showing signs and symptoms of hyperoxemia, if you are blasting them, if you are flooding that particular person with oxygen, you are doing more harm to them than good. So normal SpO2, normal ABG gas, no concern with oxygen, there is no reason that person should be on oxygen gas. You are overdosing them on oxygen. You are giving them an excess medication they do not need. That is what it means. Now, precautions. There are some patients that you will also find in your practice, in your clinical practice, that are at risk of hypercapnic respiratory failure. What does that mean? Hypercapnic, that's CO2. So I'm going to break that down when I get to ABD. So hypercapnic is, there are a lot of patients that might be in that degree. Like, for example, now, some patients that breathe less. What do I mean by breathe less? Imagine COPD patient, they got a barrel chest, and so expirations is one of those things they struggle with, is expiration. So they've got a barrel chest. So they'll have a likely chance to retain CO2s more than expected in their blood. You can find patients like that. You can find some patients with ascending paralysis, like all these GBS, motor neuron disease patients. You can find them. Or you could also be patients on the ward. Maybe now they are overdosing them on opioids, narcotics, or all these oxycodone, morphine. I have seen a lot of them here in the UK. That I'm like, well, I'll just do it. So I'll just check their medical notes. I'll just speak with the medical team. You need to reverse this patient. Because otherwise, this patient will just go into respiratory, they'll go into coma, and that's the end. So now, so precautions, if you have that kind of patient that are at risk of type 2 respiratory failure, hypercapnic, don't worry, I'm going to explain those terminologies later on. The hypercapnic respiratory failure, so you don't want to overblast them oxygen, because generally, because they normally breathe less, even though it's an old concept, they normally breathe less, so they've got little amount of oxygen in their blood normally. So but high amount of CO2 in their blood. So if you overblast them with oxygen according to the old concepts and the hypoxic drive concept, what that means is they have a big chance to start retaining CO2 in their body. I'm going to explain those things later on, but for now, let's move on. So you want to take cautions when you see that kind of patient. You want to take caution with them. Of course, the medical team will set their target SpO2, what we are looking at. They're going to set that for you. So, and again, if you've got a patient that they've got myocardial infarction, so those kind of patients, you want to be careful with them, because when you blast them oxygen as well, you can actually make their infarct size to get increased as well. So you need to be careful with that. Even stroke patients, acute stroke patients with no hypoxemia issues. Don't forget, your brain during the acute stroke, acute attack, your brain is this vulnerable. Is still vulnerable to further attack. So now, if you overblast them with oxygen, same thing with myocardial infarction. What you are doing is you are using that oxygen to cause a kind of to suppress vasoconstrictions. So if that happens, so there will be less blood flow to some areas of the brain. So you are actually, you can even make that stroke conditions to get worse. So you want to be careful with adding oxygen. So all right, what are the risks if we overgive somebody oxygen? What can happen? I have mentioned some of them already. There's another one I've not mentioned here, absorption atelectasis. What that means is generally in our lungs now, you and I, we've got nitrogen in our lungs. And this nitrogen is an inert gas. It doesn't participate in gaseous exchange. So when you now flood somebody with oxygen, what is going to happen is the oxygen is going to display their nitrogen in their lungs. So, and what does nitrogen does in our lungs naturally? So what they do is they try to prevent our lungs from being collapsed. They are inert gas. They are just there to guide our lungs from collapse. So now when you now overgive them oxygen, what you are doing is you are forcefully driving away the nitrogen in their lungs. And what happens in the long run? Their lungs will collapse. So, and I have talked about another risk, the reversals of hyperoxic drive. That was the one I was explaining about. Let's say patient with COPD, or they've got muscle weakness, they cannot breathe very well, like DBS patients or motor neuron disease patients, because of their weaknesses they've got. They cannot really breathe. They breathe less. They throw out CO2 less. They puff out CO2 less. So they have chance to retain CO2 in their body. So the oxygen is normally very low in their body. If you blast them oxygen, they have a chance now to start retaining more CO2. If the patient retain more CO2, there is a risk to that as well. They can go drowsy. They can be very confused. They can go into coma. And okay, let's make it practical. If I ask you now to hold your breath, if you hold your breath now, if you hold your breath, what that means is you are not throwing out CO2 and you are not getting in oxygen. So what does that mean? If you do that for longer period of time, you can start feeling dizzy, you can start feeling headaches. What does that mean? Because there is no CO2 in your blood. The CO2 in your blood is now going low. That is meant to go and be driving your breathing in your medulla. I'm going to explain those things. I'm just trying to make it very simple. I don't want to start complicating things for us. So that's that about that. Again, if you overblast somebody with oxygen, they are now on oxygen mask for longer period of time. You can start seeing pressure damage in their nose, in the ear, and all of it. And again, if you overblast them with dry oxygen, what will happen? You can start retaining secretions in their chest, their airway will start drying off, and all of those things. So we need to really, really very careful with over-oxygenating our patient. And again, in acute deteriorations, if you overblast somebody oxygen, you might not even know your patient is dying. So that is why we need to really, really careful when it comes to handling of oxygen. Are we still there? I hope I'm not too fast. Hello, reactions, please. Are we still there? Yeah, perfect.
Yes, yeah.
All right, yeah, all right. So let's crack on. So now I mentioned target SAT. So what do we mean by target SAT? So target SAT, So target SAT is just a guidance that will let us know how amount of oxygen are we supposed to be giving this particular patient. Now, I have mentioned some patients that they normally naturally have low oxygen in their blood. So their target SAT, generally, physios don't do this. This will be done by the prescriber. Who is the prescriber here? So your medics are the prescriber, your doctors are the prescriber. In advanced countries like UK, for example, you might find advanced nursing practitioners that can prescribe that. They can tell you, that can prescribe oxygen, that can prescribe medication, that are independent prescribers, that can also tell you the target SAT of a particular patient. You can also find some physios doing that. Yeah, advanced clinical practitioners, physios, yeah. So that can also do that. They can also prescribe oxygen. They can prescribe medications as well. So these are people that will set the target SAT for a particular patient. Their stuff we look at, their stuff to check when it comes to setting the target SAT. But one thing I want you to remember here, there is something we call scale 1 and scale 2 here. Scale 1 is just patient that normally they are fine. They have just close to normal oxygen, 100% oxygen that everybody should be having in their blood. These are targets, scale 1 patient. Greater than 94, greater than 95, 96, 100, fine. Of course, you can't go beyond 100. So greater than 96, blast them, no concern. So they are fine. These are scale 1 patients. Now, that means if somebody is placed on scale 1, I should be expecting their SpO2 to be greater than 94, 95 and above. If they are like 93, 91, they are not saturated. That's what it means, if that makes sense to you. Now, there is scale 2 as well. Scale 2, these are patients that normally breathe well, if you understand the previous explanation I made. Like, for example, now they've got low oxygen in their blood. These are like patients like COPD, morbidly obese patients, DBS, ascending neuro, any patient that can hypoventilate, they will normally fall into this category. These are 88 to 92. That does not still mean, for example, now, normally when a patient comes to the hospital, these are stuff we will expect our medical team to be doing in case of acute deterioration. They should make that plan down. When you check their notes, even if we will not be giving them, blasting them on oxygen while they are in the hospital, at least we need to have that knowledge, because in case of deterioration, so that we know what to be doing with them. Now, so even let's say now, for example, these things are not available, and I've got a patient in front of me now, and I just look at their case note and I say, yeah, chronic COPD, they've been having it for a while. Yeah, I can just have that rough estimate in my head. Yeah, the saturation should be between 88 to 90. It's as simple as that, if that makes sense to you. But you are not prescribing those things. You are not making that decision for a patient. And sometimes it could be that could be a clash in knowledge. That now the medical team are saying, yeah, the patient should be, even though you've seen a clue from their personal liquid that the patient should be around 88 to 90, and they are saying, no, we want it to be 90 to 92. Yeah, it's their job. Just work with whatever they are saying to you. Yeah, it could be some other things they are looking at for them to have come down to that decision. You don't have to fight them. No, just go with whatever that is what the policy says. Just go with whatever they are doing, because there are a lot of patients. Let me give you an example now. Let's say somebody have got let's say congenital heart disease, for example. Now there is something from the right heart to the left heart, something like that. So you can find in those particular patients as well, because there is meeting of oxygenation and deoxygenation of oxygenated blood. You can normally find their saturation to be low as well. It could be between 75 to 85. There are some patients in that category. And there are some patients, when you check the medical need, they will say the target SAT is between 90 to 92. Work with that. You don't have to combat that. Just work with that. It's as simple as that. But generally, what you will normally find in acute hospitals is target SAT, scale 1, greater than 94, 95, cool. Scale 2, 88 to 90. If that makes sense to you. All right. I popped something here, which I will just speak briefly on it. What's the difference between SpO2, SaO2, and PaO2? SpO2, like I mentioned, is just the concentration of oxygen that you've got on your hemoglobin. Simple as that. Your probe, you use that to check that. Now, SaO2 is just SpO2 is just non-invasive. We are not putting cannulas through their blood veins or through their arteries to be checking their blood, to be checking their arterial blood. We are not putting any cannula. We are not going invasive. That just pop something in someone's finger or in their hair or in the toes or something, just to check the readings of the oxygen. Now, SaO2 is just the arterial. Now we have gone invasive. Now, so if I want to document that, when you look at the screen and you find sometimes you even see it as SpO2, but no, sometimes ideally it should be SaO2, because we have gone arterial now, we have gone invasive. But when you see it as SpO2, if that is what everybody keeps writing in the hospital, that's fine. Move on. See, we are only worried if we are doing things or we are not doing things that is affecting our patient. That is when everybody becomes, they start raising an eyebrow. Things like this, nobody worries, move on. Now, PaO2 is just now the oxygen that you've got in your plasma. I'm going to talk about that when I get to what's it called, blood gas. So, all right. So now, reasons for DSAT. These are all these things I've been saying is just to build background, to let us understand some basics about oxygen. So reason why somebody can have decreased SAT. For example, now if I pop a probe to a patient, let's say they are breathing on room air, they are not even on oxygen now, and they've got COPD, chronic COPD. If I probe on them, yeah, and their saturation is saying 89, 92, will I be worried? I shouldn't be worried. And again, if that still doesn't mean if you pop problem, you cannot find their saturation to be 94, 95. You shouldn't be worried. I can only be worried let me go back to that. I can only be worried for somebody that is meant to be on a scale 2. The only reason I can be worried if their saturation is greater than this is when they are on oxygen. If they are on room here and their saturation is greater than this, their body will compensate and balance things. I'm not worried. If that makes sense to you, let me say that again. I can only be worried for a patient on oxygen that are placed on scale 2, if their SAT is greater than, if their SAT is more than 88 to 92, only if they are on oxygen. If they are on room here and their SAT is 94, let's say for example 94, I'm not worried. You should be worried, if that makes sense. So now some patients like that, and again, let's say like I mentioned, let's say you've got a patient COPD or motor neuron disease patient now, or somebody that normally hyperventilate, obese patient, that we should normally see less oxygen in their blood, and you probe them and they are saying 92. Should you, and they are on room here, even if they are on oxygen, do you want to be worried as a physio? The answer is no. These are normally patients that have chronic hypoxemia in their blood, but we are not worried, if that makes sense to you. Some other reasons why you can find somebody having a low SAT is let's say they've got of course hypoventilation is the first one. If you've got diffusion issues, let's say for example now somebody have got this poor ventilation here. Let's say somebody have got lung collapse, atelectasis, or they've got pneumonia, really bad chest infection, lot of sputum retention here, or you've got somebody with fluid, maybe cardiogenic or non-cardiogenic, like pleural edema here in the lobes. In that regard, oxygen will really struggle to diffuse down to the blood vessel here. So in that regard, their SAT can start going low. That makes sense. So now some other reasons you can find is diffusion impairment. Let's say for example now diffusion impairment. Let's say the alveoli wall becomes, now let's say the alveoli wall becomes thicker than expected. Normally alveoli wall is, I think, is about 200 times thinner than your skin. Imagine now it's now getting thick. I say, like for example now in a patient like pulmonary fibrosis, let's say they've got ILD, intestinal lung disease. So these are stuff that will make diffusion difficult for patients. And don't forget, remember your is it physics now in secondary school? Diffusions. The longer the distance, the difficulty is going to be difficult for diffusions to take place. But short distance, big diffusions. And again, so remember that thicker membranes. When you have thicker membranes, diffusion is going to be slower. It's as simple as that. So so that's that. The other one here is if you've also got a patient that they've got issue with ventilation, perfusions. These are stuff we normally hear people talking about, especially in the hospital. VQ mismatching. What does that mean? Let me just explain in simple terms. Ventilations here, perfusion, blood. Here and oxygen. Here, oxygen and blood, they are like husband and wife. They love to go out. They love to do stuff together. So if there is a problem with here, there's a problem with oxygen, definitely your oxygen, your blood will have an issue. If there is problem on the blood, maybe circulatory system now, their blood, there is issue with circulations now. The oxygen too is going to be affected. That's how it works, if that makes sense to you. So generally there is a way our body tries to compensate for that. I don't know if I can quickly explain that here. Let's say, for example, now there is an issue here. I know I'm saying a lot of physiology here, but we need to really understand this. So yeah, let's say there is an issue here. Let's say this patient here, if you look onto the screen, we have written poorly ventilated lungs. Let's say there is an issue there. Let's say this patient has got chest infection, they've got pneumonia now. So the rate of diffusion of oxygen is low here. So what does that mean? That means there is a chance that blood will start flowing to that lungs and they are not getting ventilated. Don't forget husband and wife now. Blood is coming. The wife is not present. Oxygen is not present. That does not make sense. So there is a way the body can compensate for that. The way the body can compensate for that is just to constrict the vessels, which some people will call hypoxic vasoconstrictions. Big term, but simple concept. Now, the blood vessel will constrict just to shunt the blood to the good part. Just to shunt the blood because we don't want to be wasting the blood that are coming down there. It's as simple as that. If you don't remember that, just remember these things. Because I want to just keep everything as simple as possible. Now, if you don't remember that, what are the reasons somebody can have low desaturations? If they've got anything going on in their lungs, simple as ABC. If they are somebody that normally they breathe very low, their breathing, their expiration is always very low. If they've got a big chest or something like COPD patient or something like that, so their saturation can be really very low. And if, for example, now I'm not going to explain that like low inspired FiO2. Let's say in the atmosphere now, we've got low oxygen in the atmosphere because we all take the oxygen we breathe from the atmosphere. If you go on a mountain, there's less chance that in the atmosphere you're going to have low oxygen in the atmosphere. So if we check the oxygen saturation there, it is possible for oxygen saturation to drop. I'm not going to explain that concept more than that because of time. Let's move forward. So please remember basic things. What have we said up to now? Let's recap because we need to be able to flow through. What have we learned up to now? We have said that oxygen is a drug. It needs to be handled with caution. You need your doctor to prescribe it. You need your doctor to set the target SAT. As a physio, you should be working with the target SAT of the oxygen. And again, how do we know if oxygen is low in the body? You can use the probe. If you use the probe, what you are checking is the SpO2. And then if you do blood gas, what you are checking is you are checking the oxygen in the plasma. It's as simple as that. That is all we've said to this moment. So let's move forward. So what you can do as a physio, we have talked about what doctors can do. They can set the tag for you. They can prescribe the oxygen for you. However, in case of emergency, do I still need doctor? This is a dying patient. I'm seeing this patient. This is a dying patient. He's dying already. So do I still need to wait for that doctor that is not even on the ward to come down for a dying patient before I can do my stuff with them? No, the answer is no. So you've got the autonomy in emergency settings, in emergency situation, blast them with oxygen. Even if you are not sure of what amount or what is their target saturation, my dear, just blast them off. Just blast them oxygen. Because at that moment, if you don't do so, their patient is going to die of hypoxemia. Of course, hypoxemia we call hypoxic. Hypoxic is just tissues dying because they are not getting oxygen. So blast them with oxygen. Because why? Because I mentioned the other time in patients that normally breathe very low, when you blast them too much of oxygen, what it's going to do is start retaining more CO2 in their blood. But that is not going to kill a patient immediately. It's not going to. But what is likely to kill a patient first is lack of oxygen. Up to now, I've been talking of two things: oxygen and CO2. CO2 is not likely to kill a patient immediately, but oxygen is likely to kill your patient immediately. So if I'm seeing a patient in front of me, they are dying, they are desaturated, I check their saturation is going 70, 69. Yeah, what are you doing? Blast them on oxygen, blast them. Even if I don't know their target SAT, I don't know. But even though this is what we want you to be checking before you go see a patient, but just imagine now, I don't even know their target SAT. I don't know if they are prescribed or they are not prescribed, or even if they are not on oxygen previously. And I check their target SAT, blast them on oxygen. That's what we are saying. So physios, in emergency settings, you can use your oxygen, and you also go, even if they've been prescribed already, doctor have prescribed them, doctor have said the target SAT, you can change the oxygen device, you can escalate them, you can win the oxygen. These are stuff we can be doing as a physio. But all of these things, we need knowledge to be able to do, and we need to be signed off to be able to do all of these things, because oxygen is essential for life. We need to be able to monitor their SAT. We need to be able to know if the patient are deteriorating. We need to be able to, and for winning as well, you need to be able to know if they are improving. So you need to see how you can work within their target range that the medical team have set already. So, all right. Again, what you can do as a physio, you can initiate oxygen in emergency situations. You can change their pipeline. Let me just show you that. I think I've got that one here. Yeah, can you guys see this? I don't know. Hello? Oh. Hello? Hello?
No, we can see you.
Yeah. So you can change this. If it's too short, if it's too long, yeah. You can change the pipe, you can swap them on another oxygen device. You can do all of those things. You can do all of those things. You can win, you can titrate, you can if I need to do my rehab, I need to do my mobility with patients. Let's say they are connected to oxygen on the wall or to the tank. I can go and get a mobile oxygen cylinder, pop them on mobile oxygen cylinder, start doing your stuff with them. So that's how it works. All right. Roles, responsibilities, because I mentioned again to Ross that we don't want staff that are not competent to have business to be doing with handling oxygen independently. No matter your level of education, if you have not, ideally, in an ideal environment, no matter your level of education, if you have not signed a competence, they have not deemed you fit that you can handle an oxygen, you shouldn't be doing it. If you want to do anything oxygen, you have to be under the supervision of competent staff. Because we know if you mess with the oxygen, you can make that situation worse. And if you don't do what you are supposed to be doing, your patient can die. So we shouldn't be messing with oxygen. So now, generally, students and part 5 students, they need to be working, of course, they need to be working on that competent staff. They need to be supervised all the time. Yeah, what they can do with us, they can assist us to measure their, pulse probe on their fingers, in their ear, in their toes, measure SAT for us. And if the SAT is low, of course, their responsibility is just to escalate to the senior competent staff. Oh, I've got the oxygen, their saturation is 92. What do you think? Yeah. So whatever they need to do must be from the supervision of the senior competent staff. And again, register staff, if you have not signed off, if you are a professor, you've got a lot of DPT, you've got this, if you have not signed off, because we have to be accountable for whatever we do for our patient. Patient must be the center of everything that we are doing in hospital. So we need to be signed off as a registered staff, registered qualified staff that are competent to be able to handle oxygen. So that is that on that. Of course, we can make our own. I just start down and think about some of these things, but it is our responsibility again as a physios in Nigeria to think about what policy can we cook together, what policy can we design, how does it work locally in our hospitals, how will that work because what can be obtainable in, let's say, Ibadan now, for example, in the teaching hospital Ibadan might be different from the ones in Usman Dan Fodio universities. It might be different. So we need to be able to sit down. Aside from the general one we can have as a physio, we can also have some local policies on how to handle some of this stuff. But again, irrespective of your policy, if you have not been signed off, if you don't have competencies with this, you don't demonstrate skills and knowledge to do it, don't do it. And you need to be under a competent staff for you to handle it. All right. Again, this is just showing us we are beginning to enter into the business of the day gradually. This is just to show us. I think I just check. I think Nigeria should be, of course, we follow the guidelines of World Health Organizations. You might find oxygen being white, the port of oxygen being white. So just connect the switch, screw it to the wall. Don't worry. Even if you are not competent to do this, let's say you don't, of course. You are not very sure in doing this. Of course, your nurses are your friend when it comes to that. They just can connect it. But you should be competent in taking oxygen off, winning the oxygen, taking it down, rehab. What amount of oxygen will my patient need to do sit to stand, to mobilize on the ward? You need to be competent to be able to do that. Yeah, you need to be able to be competent as a physio to be able to connect oxygen, your patient to oxygen cylinders, mobile oxygen, portable oxygen for rehabilitations. So, all right. Again, this is just showing. I don't know if you look at this picture here, this is just showing what you will normally see. Like you're going to see a ball. This is like showing 2 liters here, for example. Now, if it goes up, it could be 3, it could be 3.5, something like that. So, and the other picture here, this one is just showing. The other picture here is just showing us. Generally, like I mentioned the other time, we are all on room here. We are taking 21% of oxygen in the atmosphere. I think we power that, we fuel that by using, I think 20 liters per minute. That's what literature have said. To be able to pump those 21 oxygen into our lungs. So generally, if a patient is on 1 liter, if a patient is generally on 1 liter, on let's say on nasal cannula, for example, we're going to talk about that briefly now. Approximately, these values here, they are not very accurate. I'm going to talk about them. They are not very accurate. But in your head, you can have it as estimately the patient is likely to be on 24. Just keep adding 4, 24 plus 4, 28, 3, 32, like that, till 10. 10 is the highest you can see on the wall. So 10 will be around 60. That's what it means. So don't cram this. You don't have to cram it. That is just the reality here. So case study here. So so we're going to start the treatment proper now on oxygen. So I've got a patient here. This lady, she's 55. She's currently on OAU teaching hospital. She's been short of breath, and at the moment she's got myelodysplastic as the past medical histories, and she's got anxiety disorder. Social histories is normally independent in all activities of daily living. Instrumental basic activities is very independent, very active. The blood, the HB 79, they've done blood. The medical team have run their blood. HB 79, the platelet is 38, the CRP is 35, the heart rate is 108, their blood pressure is 180, 128 by 80, and your patient is conscious. This lady is still conscious, and their SAT is 85. So I need us to speak here. I want to take some rest. So I need us to speak. So can you analyze this? What are the problem lists? Yeah, I think we have trainings on blood the last time. So what can you see here in this lady? This patient is just short of breath at the moment. She's normally very independent. She's got anxiety disorder. She's got dysplastic plasmodic injuries, and the blood is available to you now. So you are the physios on call now, or your normal regular day work now. The medical team have just called you to come see this patient, or you pick them up by yourself. So what do you think? So please, can you open your mic? And somebody, please, let's open our mic while others are speaking. The rest of us, we can pop our answers in the chat box. I'm going to be reading the chat box as well. So yeah, let's pick up. What do you think about this lady? Can you analyze this problem for us? What can you see here? What is the lady's biggest concern here? And what do you think as a physio? What do you think is going on? Yeah, please open your mic. Let's hear you out. Can you guys hear me? Somebody just mentioned they can't hear me. I don't know. Please, can you hear me, please? Yeah? Hello?
We can hear you. We can hear you.
Yeah, perfect. Because somebody just pop in the chat that they can't hear me. Sorry about that. I think you might need to check your network. Yeah, please, what do we think, guys? This is a lady now. She's currently in the emergency setting in OAU Teaching Hospital. Yeah. So this lady is currently struggling with shortness of breath. So what do you think? Yeah. Please, let's pick up. Let's open our mic. Yeah. Guys, pick up. Let's share knowledge. And I don't care if you are right or you are wrong. This is just clinical reasonings. Yeah. I don't care. Yeah, just say whatever you see here going on with this lady, connect the blood, connect it with their presentations. What do you think as a physio? Yeah. Hello, who is speaking, please? We need to speak up. Speak, speak, speak. Yeah, please open your mic. Yeah, I can see your hands. Open your mic. Open your mic, sir. The host is, please open your mic. Guys, we need to speak, otherwise, because if you don't speak, my brain works with feedback. My brain generally works.
Good evening. Good evening,
Yeah,
sir.
yeah. Good evening, Maya.
Hello, sir. Can you hear me?
Yeah, I can hear you. Yeah.
Okay, let me allow you to speak first.
So I said, let me attempt. So
Go
it's
ahead.
my first concern here is the oxygen. Yes, the oxygen level is low.
Okay.
So there are so many things that we can't commence at this level. We have to top up the oxygen to about 90 or 95% before proceeding with other things. So we can commence with 1 liter of oxygen.
Okay.
So apart from that, the hemoglobin level is too low.
Okay.
So
Sorry
that
again,
one
everyone.
also will restrict us from doing. Hello?
Yeah, I can hear you. Yeah, I wanted to apologize that I didn't put the normal value.
The hemoglobin level is too low.
Mm.
So in that case, I can also.
Hello.
Hello, sir.
Yeah, I'm still here with you. Yeah.
Hello, can you hear me?
Audibly. Yeah.
Hello.
Yeah, speak on. Right on. Oh, I think it's his network. Yeah, please. Yeah, please speak. I really need us to speak.
Let me
Go ahead.
attempt this. For this patient that is 55 years old,
Hmm.
so the first thing I'm noting here is the severe hypoxemia because of the SpO2 of 85%.
Okay.
Then another thing is the platelets. So it's also showing that the platelet is low, which could also precipitate that the patient could have also high bleeding risk from our last class.
Okay.
Then I could see that the patient is also has tachycardia, which could be related to physiological stress.
Okay.
Then the CRP also shows the infection and ongoing inflammation from the infection.
Okay.
Then also, you noted that the patient has anxiety disorder, which could also be contributing to dyspnea, if I'm not mistaken.
Okay.
And in terms of treatment here, I would consider having these patients first off on say face masks. I don't know if that is quite that, and target SAT to be above 92%,
Okay.
maybe as a protocol.
Okay.
And that is it for now.
Okay. Thank you very much. Yeah. That's a great contribution. Thanks a lot. Yeah. Of course, people have started typing in the chat box. Yeah. Ongoing inflammations and tachycardia. Yeah, that's cool. The CRP is rise. Low platelets, low hemoglobin, problem list. Great job. Thank you. Please, we need us to, I really need us to be up and doing. I need us to be, So what do we think? More response, please. What do you think, physios? Physios, what do we think? What do we think? This is our patient. You've got this lady in front of you now. She's really short of breath. Yeah, and these are the bloods. These are what you've got in front of you. We don't know if they've done any scan or whatever, but we know, yeah, from here we've got our social histories and we've got the blood. This is what we've got. And we've got our hubs, vitals. So what do you think of this lady? What do you think is going on? Yeah. We've got 2 speakers over. Please, I need at least 2 more persons before we can move forward. Please, we need to speak up. It's not me coming to doing this job alone. It's a joint work. We need to do it together. Yeah, speak up. Time is going. Speak up, please.
All right. Good evening. I don't know if you can hear me.
Yeah, audibly. Good evening, ma. Yeah.
All right. Thank you, sir. Okay, so with response to what we have on ground, so looking at the values you've placed before us, our hemoglobin level is low, but owing to the fact that our past medical history is indicating she might be having I just checked up that myelodysplasia because I didn't know it before, and it's in relation to a stem cell disorder. So our blood count level by reason of that condition is low. And so if that is an ongoing, then we have to be mindful that this condition is something chronic, and so there is definitely a need to initiate oxygen. Although, because we don't want a case where we're not certain of our target SAT currently, the saturation level, we're not sure, although it's obvious that she's desaturating by that 85%. But for the fact that she's conscious, we can reassure the patient. We can try to calm our nerves down because of the previous history of the anxiety disorder.
Perfect.
While just possibly just initiating a very low level or maybe like the 1 liter of oxygen just to observe her and see how she progresses. And of course, as a physiotherapist, doing exercises like forcefully breathing may also play a role to, as it were, reassure the patient and just train her to calm her nerves down, as it were, while still maybe waiting on further information, whether to, if the conditions deteriorate further, maybe we would have to increase oxygen level or do any other thing. I won't be too worried about the heart rate yet, because I mean the borderline, what we have is the 60 to 100. 108 is still okay, still fair. For a 55-year-old patient, I don't have an issue with that. So for me, I think that's the priority. Reassure the patient, possibly via oxygen nasal cannula, send in like a 1 liter of oxygen, and then watch as her progress continue, knowing fully well that this is a condition that could, as it were, alter over time.
Yeah,
thank you.
Cool. Thank you very much. Thank you very much. From what you just said, it seems like your biggest worry is the SAT, and thank you for connecting the past medical histories with the patient. Yeah, thank you very much. Let me get one more person before we crack on. Yeah, who is there? Yeah, please speak up. Who is there? One more person. Let's get your opinion. There's no right or wrong. Of course, we don't really care here as well. Yeah. One more person. One more person. Yeah. Go on, sir. Your hand is up. Zoom user, raise your hand. Sorry about that. I don't know your name.
Okay,
Yeah.
this success, sir.
Oh, all right, ma. Welcome.
Okay. All right, so sir, my concern is going to be the SAT level and also the platelet. In as much as the SAT level is not really that desaturated, it's 85%. I'm not going to be giving much, and I'm worried about the platelet, which is less than 50%. And
Okay.
because there is no scan run, it's going to. I need to get more because this patient is at high risk of having bleeding. Any part. So I'm worried about the platelet being low, sir. But I'm just going to go for safety reasons to improve the oxygen saturation. I'm just going to give maybe 1% of oxygen. I will not want to over saturate the patient.
Yeah. Cool. Thank you very much. Thank you very much. Of course, these are brilliant responses from everyone. Of course, one thing, if there is one thing I'm going to modify here, is going to be for every patient, for every questions you've got, put it, or for every investigations you see in front of you, either blood, either scan, or whatever for a patient, put that in the context of that particular patient. We need to be able to connect the past medical history with their presentation with the past medical history, with the blood, with the scan, or whatever it is. I think putting all those things together is going to it's going to give us a chance to make a good decision for our patient. Now, if you look at it, if you just ignore the past medical history, if you just look at the blood, let's say I'm working on the ward, somebody just give me this blood. In my head, I'll be like, 79, yeah. Maybe below the borderline from what we spoke about last week, if you remember. Oh, platelet, maybe below 50. Yeah, I might be worried. Oh, this patient might be spontaneously breathing. Bleeding. Might be worried. 35 CRP. That's infection. That's really very high from what we explained last week, right? Now their vitals. Now you've got their ups, their heart rates. Maybe a bit high, but 55-year-old. Yeah, maybe I'm not too worried, but their blood pressure, okay, their SAT now. This patient is still alert and their SAT is 85. What is going on? SAT is dropping. So the other question we should be asking ourselves is, look at the SAT. What is likely to kill this lady, first of all? That is the question. What is likely to kill this lady, first of all? The likely things to kill this lady, first of all, is going to be the low SAT here, from what we just see here. Now, what could be driving the low SAT? Forget about past medical history now. It could be, the SAT could be, this lady is really, really, maybe at the moment is very panicked, just like what somebody mentioned. She's very anxious. She's not even settled at all. It could even be from chest infections. It could be infections, CRP. You start connecting those things together. Could it be from infections? Could it be this? Could it be that? Yeah. Will it be now? And again, if you now need to go back to the past medical history, from the past medical history here, you can see there is an issue with the what's it called now? There is with the cells in the bones that are making blood. Yeah. So now that means naturally in my head, I might assume that the blood cells, some of the blood cells might likely be chronically low. That is what that past medical history should be telling you in your head. Might likely be chronically low. For example, the platelet might likely be chronically low. Maybe prior to her coming to the hospital, she might have a baseline of platelets of, let's say, 50, 40. It's very possible. Yeah. Now that she's now got chest infection, remember what she's now got infection. We don't know what infection she's got. The CRP just remember I told you CRP is just non-specific, but we don't know the particular infection she's got now. Now she's got infection now. Like I mentioned to you last time, infection, if it is platelet, can be high or low if somebody has got an infection. So could it be that now already we know that she's coming from a low platelets background? Now that she's got infection, could that infection also be impacting on this patient as well? These are what you are thinking as a physio. So now, if I really need, let's say now I need to do stuff with this patient, I might need want to check with the medical team. I'm worried about this. I know they've got issue with their blood cells. Regarding the platelet, do we by chance do we by chance know their baseline of platelets? You want to ask those questions. Now they might say, yeah, I think 40, I think these things, or can I be, even if they say no, you can just say, yeah, do I have to be worried on their platelet because of this? Connect those things together. Or is there anything you guys are doing actively on their platelet or on their HB, for example? You want to ask them those questions because because of their background, they are coming from a low platelet, low blood cell background. So you want to ask them those questions. If they say no, they are not for transfusions, they are not for platelet infusions, then nothing stopping you. Then as a physios. And again, like I mentioned, if you need to do stuff, go to their bedside, assess if there is bleeding, if there is ask the nursing staff in charge if there is any bleeding or anything. If there's no concern, you can do your stuff. Now, what is going to kill this lady for because of time? Low sat. So what do you want to do? Blast them on oxygen first of all. But before you blast them on oxygen, do you want to do some physio stuff with them? Somebody coming from anxiety disorder, like somebody mentioned. Do you want to do some reassurance? Do you want to use some distraction grinding techniques to get them settled? These are what you want to start doing. And again, you've got reasons why you need to blast them on oxygen. What is the reason? Low sat, blast them on oxygen. But imagine somebody is coming with anxiety disorder, very short of breath, but there is no evidence for me to blast them on oxygen. If you do so, your competency for oxygen management needs to be queried. That's what it means, if that makes sense to us. So that is this lady now. If we've got another man here, this gentleman is currently on Udut Teaching Hospital. He's been immobilized for a while now because this man had a fall. He's been immobilized because of pain. So now he is very, very confused. He's very confused on your ward now, and he's really, really desaturating. That's desaturated down to 80. So now they've done imaging. There's no deformity. We've got the blood parameters here. We've got their past medical history as well. Very independent, very active man. And now, can we make sense of these things? Can we connect these things? Yeah, can we connect these things, please? Yeah, who is speaking? Just two persons and we move forward. We've got a lot to run. Two persons, please open your mic, speak up. It won't make sense if I just come here, I run the stuff, I go away. It does not make sense to me. So let's interact. What do you think? This person, this gentleman, what do you think? What are the issues there? Who is speaking? Hello? Physios.
Hello, sir.
Yeah. What do you think,
Yes, sir.
ma'am?
Okay, so looking at based on what you shared with us from the last class we had, we can see clearly that the sodium level is very is low, is below the normal range. Obviously, the CRP2 is very elevated, saying that there is an ongoing infection. Same with the white blood cell count too. Even the creatinine level too is elevated. So, and this is an elderly patient that has been recumbent. He has been immobilized in bed for a while, though the duration cannot be certified right now. But for the fact that it's actively desaturating at oxygen level of 80%, honestly, for me, I think the saturation is still going to be the first thing I would be after, because he's already getting confused, meaning the oxygen level being supplied to the brain is diminishing. And we don't want a case where full cell damage will begin in the brain and all of that, being an older patient. So I would most likely be concerned of what's the word now? Infusing with oxygen first of all, while I track to see and see how that is going to have an impact on the other blood tests that has already been done. But definitely oxygen is priority to me. Yes, before any form of plan for further mobilization out of bed, because he can't even follow the command. He's confused. He can't do anything at that very time that would help him to get out of bed yet until the oxygen level has been corrected.
Yeah,
That's
sounds
what
good. Sounds good. Thank you very much. Thank you very much. Good contribution. Great one. Yeah, one person, one more. What do we think? I know we've got excellent physios on the call. Please, what do we think? This is a man now. So this gentleman is really down. The SAT is going down. He's confused. He's struggling with pain as well. You've got the blood in front of you. You've got the imaging. Yeah, you've got the social histories. Yeah. So what do we think? Can we make sense of these things? What do we think? Yeah. One more person, please. Speak up. Speak. Open your mic. Yeah, who is there? Who is speaking, please? Oh, time is going. We need to speak up. I won't be happy to go forward if we are not speaking. Honestly, we are all physios. We are here to share knowledge. We need to be speaking. Yeah. And we've got a lot to cover. Time is going. Speak up. Who is there to speak? One more.
Okay,
Yeah.
sir, let me attempt.
Go on. Thank you. Go on,
So,
ma'am.
so this patient FPOC is showing up 80%, which is also severe hypoxemia. And then with the hyponatremia, I'm noting patient could likely be confused and likely okay, and that the creatinine is suggesting because of a prolonged immobilization that is relating to that, and also the CRP and the white blood cell counts is also showing us a recent infection. Okay, and then the imaging is not showing any abnormality. Okay. So for me, the thing that will be coming into my mind is that this patient might actually be having respiratory failure on the sideline, and then with the issue with the confusion and prolonged immobilization, I would my major concern would be not to proceed this patient with routine physio management.
Okay.
My concern would be to start off on I wouldn't know high non-rebreather face masks at this stage.
Okay.
At this stage, and then target that the SpO2 comes up to greater than 94%. For this patient. And also relate with other medical professionals and see what the ABG says.
Okay, cool.
To interpret that. And if there's if the medical team now deems it fit that they would escalate in terms of the oxygen therapy, they will take it from there.
Sounds
That's
good.
what I think.
Thank you. Yeah, thank you very much, Bob. Yeah, Mr. Success Hebel. Yeah, speak up. I'm happy as many as we can. Let's speak. Let's share knowledge, because the more we interact, the more we get this concept. Yeah, please speak up, Mr. Success. Yeah.
It's me, Success. Okay, sir.
Sorry. Sorry.
Okay, sir. I'm looking at the markers I have here, the creatinine level, because of he is immobilized. So there is a muscle breakdown, and the confusion. Looking at now, the state of confusion could be linked to this desaturation. So the brain is not receiving much energy, oxygen. So that is why we need to tackle first the saturation. So the first thing I'm going to do now, I'm going to put oxygen, place this patient on oxygen. Then I will start with other bed exercises I will do, so that I can come up with more of the oxygens to utilize the ones in my surroundings.
Yeah. Okay. Thank you very much, Miss Success. That's a brilliant one. Like I keep saying, put everything you've got in the concept of your patient, adapt whatever things you've had in front of you, put that in the context of your patient. This gentleman is confused. Why is he confused at the moment? It could be because of the oxygen, like Ms. Success just mentioned to us. It could be because this gentleman has been immobilized for a while in bed. How do we know that there is an issue going on? The creatinine is shooting up. The creatinines now, the sodium is coming down. There could be an issue with dehydration. Maybe this man is even dehydrated at the moment. And I want to, when I go to their bedside, I want to look at things like that. Dehydration, observe for that. Yeah, it could be an infection. Infection could be driving his confusions. The dehydration, sodium issues could be driving his confusions. The creatinines, like we mentioned last time, the creatinines are just showing you that, oh, there's an issue going up with muscle breaking down, rhabdomyolysis issues with this gentleman. Yeah, white blood cells, you can link that with confusion as well. So now, all of those things, putting those things in the context of a patient, then at the same time, what is your biggest concern at the moment? Your biggest worry at the moment is this desaturation. So what do you want to do? Commence an oxygen therapy if you are at their bedside. Let's say previously with the medical team, they were 98. Now with you as a physio, 80%. So what do you want to do? Establish what their targets are at it. Commence oxygen therapy. That's what it means to you. So who is going to administer this oxygen for us? Maybe Miss Success will help us. So let's crack on now. Why is it not responding? Okay, so let's crack on now. Before we talk about oxygen in details, again, I want to spell these things and I really want to make it very clear to us. Whatever change you make for an oxygen, everything has to be documented. Your observations before you blast them on oxygen, document it. After you blast them, after you flood them with an oxygen, document it. What is their vital signs after that time? What flow, what liters, what mode of delivery, what intervention did you have with them? Why they are on oxygen? All these things must be documented clearly in your notes. All right. Now, I'll come back to this slide. Let's talk about oxygen first of all. Now, when we talk about business of oxygen generally, there's something we call low flow, there's one thing we call high flow oxygen. So now, anything less than 35, clarify as low flow. I don't know, people, I think people are complaining about network not being audible or something. I don't know if the admin can please just, the organizers can please just look into that. I don't know. So now, like I was saying, low flow is just anything less than 35. High flow is anything
Sorry, sir. Hello, sir.
Yes, sir.
Hello, sir. I think the network is from their side.
Okay.
I think there's one guy from Maiduguri, Dr. Abdurrahman. The network was shut down there, so the network is from individuals. It's individuals' problems generally. Thank you, sir.
Okay. Thank you very much for that clarity. Please, let's check our network so we can enjoy ourselves. So now, for nasal cannula generally, if you look at this, let me show you in another picture. Why is this not? Yeah. So if you look at this now, if you look at the picture, yeah, you can see this is just nasal cannula. Some people will call it nasal spec. Some people will call it nasal prong. These are stuff that goes, they've got cannula that goes into your nostrils. That's what it means. So generally for nasal cannulas, yeah, we want to know, the other time I mentioned your calibrations on the wall or on oxygen cylinder, it can go as high as 1 to 10. But generally for nasal cannula, we don't want to go beyond 4. Anything beyond 4 is putting your patient at risk because this is a dry oxygen. So the airway of a patient can really be very, very dry. We don't normally want to go anything above 4. 1 to 4 is fine. And what are the advantages of nasal cannula? You are just popping cannula through their nose. This patient can speak, they can eat, they can drink, no concern here. But now remember, you just put some tiny cannula through their nose. Ear can see this. That does not stop this patient from breathing normally, from taking air through their nose normally. Or even while they are talking, they are also shocking, indirectly shocking from here through their mouth. What does that mean to you as a physio? So what that means is those here, room here, the air in the atmosphere, they are indirectly shocking that are coming through their nose, through their mouth when they speak. Those here are also interacting with the oxygen we are giving to this particular patient. I make it clear. If you look at your screen now, if this is a tube now, it comes directly from the oxygen cylinder. I put a nasal cannula. This is being connected to a nasal cannula now, for example. Now, from this tube, from the oxygen cylinder, 100% oxygen is coming. 100% oxygen. No mixture, no nitrogen, no noble gas or whatever thing. 100% of oxygen is coming from the cylinder. So by the time your patients start breathing air in the environment, they start taking in atmospheric oxygen, they start through their nose, through their mouth. The air, the environmental air, the air around, the air they're shocking, is going to mix up with the air you have given to them. So it's really difficult for us to establish. By the time we give somebody a nasal cannula, like you pop this nasal cannula on somebody, it's very difficult for you to establish what amount, what concentration of oxygen are they really getting? Are they actually getting? So that is why if I want to document, let's say I've popped nasal cannula 2 liters on somebody, on patient. Now, if I want to document, we don't like documenting 24 liters, 28%, 28%, 24%, 35%. It's not very accurate for a nasal cannula. If that makes sense to you. If I pop 2 liters on something, I'm going to just document 2 liters of oxygen via nasal cannula, nasal prong, or whatever you want to use, and their saturation is this. If that makes sense. But roughly, yeah, we can see, yeah, if I give 1 liter, it might be 28. If I give 2 liters, it might be, if I give 1 liter, it might be 24. If I give 2 liters, it might be 28. But know in your head that these are estimated values, and they are really difficult. If you really want to give somebody a very concentrated amount of oxygen, you need to be thinking about some other devices, non-nasal cannula. if that makes sense to you. So one thing, remember, nasal cannula is a low flow, less than 35, less than 35, 36, 1 to 4 liters you want to normally give for a patient. And again, is not a fixed, it cannot give you a fixed fraction of oxygen. The fraction of oxygen, they call it FiO2. So it's a variable oxygen device. Variable, they work variably. So we are not even sure if I give you 1 liter, we are not even sure if you are getting 40%. That's what we are saying here. If that makes sense to you for nasal cannula, so if you really want to go on nasal cannula, just 1 to 4. Yeah, that does not still mean in case of emergency, I'm at the bedside. My patient is desaturating, 80, 79. And I've got nasal cannula. I will just bring it up, bring it to 5, bring it to 6. For that particular moment, even though you know, ideally they should not be going more than 4. But in case of emergency, you can still bring it up. Then after that, you can now say, okay, now let me get me another oxygen device. Let's escalate them onto another oxygen device for them to to prevent airway dryness and some other things, if that makes sense to you. So just remember those brief things about this nasal cannula. So this picture here is just showing us another factions of nasal cannula. And again, sometimes too, if you've got evidence of secretion retentions, your patient is standing cracky and chesty, nasal cannula can also be connected with bubble bottles, like you can see here. You can find patient like this, but generally before you humidify it, you give patient an humidified oxygen. What do I mean by humidified? Oxygen that oxygen that is oxygen plus with water vapor. Think about it. Your patient, there must be an evidence of secretions, like, oh, this patient is now standing very, very chesty now. Even on nasal cannula, generally what I do, if patient is nasal cannula, they are standing chesty. I don't even think about bubble bottle or whatever. They are nasal cannula, they are maintaining their SAT, but they are standing chesty. I'll just ask the nursing staff, I'll just speak medical team, give them prescribed net for me, hypotonic nerves, 0.9. You even tell them, they will ask you. These people will ask you, what amount do you want? What is the dosage? You tell them the dosage. That is why your knowledge of blood, your knowledge of drugs is also very important. Just pop them, the nurses on the wards, they will continue to give them PRN nebulizers. So anything above 4, let's say for now, anything above 4 now, and they are standing chesty, I might now start thinking about, okay, do they need humidification or something like that? And even my humidification might not necessarily even have to come with nasal cannula, but just be aware. You can also see patients on 1 liter, 2 liters, 3 liters being connected with humidification devices like this. That is what this slide is just showing us. Now, and again, if you are on PID wards, I'm not going to speak on this because PIDs are another domain. They are another set of, they are another PIDs generally is another domain. I'm not going to speak much about this. They are another breed. So just remember that you can also find something like this, head box. It's just they are just one of the variables of nasal cannula as well, but I'm not going to speak on this. Just be aware of that. Let's come back home. Simple face mask. So simple face mask is another oxygen device. Let's say now my patient is at the best. I'm at the bedside with the patient. My patient is not saturating on 4 liters. And I think, okay, I can still go high up. I can go from 5 to 10. Yeah, if I want to go from 5 to 10, I might need to start thinking about simple face mask. But believe me, there are some hospitals you will not even find simple face mask. Instead of simple face mask, you can find some other oxygen device. But if it is available in your hospital, that's fine. Pop them on simple face mask. That's how it works. And again, same thing about simple face mask. Same thing. Simple face, and same thing is just variable oxygen device. Because when you pop this on someone's face, what it means is, here room here can still keep dropping, can still coming in and out of patient, entering into the patient airways. That's what we are saying. So it's still not very certain. If I give you 5 liters, the fraction, the equivalent of that, what's it called now? The equivalent of the concentration of oxygen you are getting that is meant to be 40 is not necessarily, it may not be even up to 40. That's what we are saying here. So it's still variable oxygen device, just like nasal cannula. And again, one thing I also mentioned here is for simple face mask, there is a chance, somebody has a chance to rebreathe the air they are breathing out, to rebreathe CO2. Generally, if you've got a patient that chronically, they normally breathe low, COPD patient, they are at risk of retaining CO2, like I mentioned, like I explained previously. That was one of the reasons why I gave those background. Now, if you've got that kind of patient, we don't like them to be on simple face mask. because chance is there that this patient will rebreathe about 1/3 of their 1/3 of their expiratory here. They will rebreathe 1/3 of their CO2. Rebreathing 1/3 of their CO2 is, if you look at the oxygen there is likely to be around 15% or something. So we don't really, if you've got a patient that are at risk of retaining CO2, we don't like them to be on simple face mask. We need another oxygen device. If you need to go at, if they are not maintaining SAT at 4 liters on nasal cannula, you might need to think about it. But if you got some patients, they are normally breathing high, they are normally on scale 1. Scale 1 is, remember, greater than 94, greater than 95 oxygen, they are fine. I can pop them on simple face mask. But if you got a patient that this medical team have said, get them on scale 2, between 88 to 92. So simple face mask is not a choice, not a good choice of oxygen device to get them on, if that makes sense to you. And again, generally for simple face mask, one thing I'm going to say again is we don't like to use simple face mask less than 5. Because when you use it less than 5, when you also use less than 5, the chance is also there, it's not going to flush out that CO2 as much as you can. There is also a chance that you start struggling with retaining CO2. So that is what, so remember, for simple face mask, I can go from 5 to 10. We don't like to go lesser. For a patient that are on scale 2, we don't like to pop them on simple face mask. That is what we are saying, yeah. So now let's move down to Venturi. Venturi mask, I'm sure some of us, we've already seen some of these things before. For Venturi mask, these are color-coded device. Let me show you in this picture. We don't have to cram all of these things because different maker has different, what's it called now? They have different delivery devices. So don't cram all of this color. But in the hospital where you work, of course, if you keep seeing patients, of course, seeing patient on Venturi, you keep seeing, there could be a particular maker that your hospital have been using. So in that particular regard, even when, for example, now where I work, if I see patient on 60, I say, if I see patient on green, let's say I'm just walking down the corridor and I see green patient on green Venturi, I can assume that's likely to be 60%, 65%. And it's likely to be on 15 because I have used this thing over and over again. But really, I don't really have to cram them. So remember that color-coded structures are Venturi mask. And originally, this Venturi mask is actually designed for COPD patients, for patients that are at risk of retaining CO2, for patients that are at risk of retaining CO2 that are on scale 2. These are best devices you want to get them on. Now, that being said, so for Venturi mask, of course, if you look at this now, for example, you've got blue, white, yellow, red, green. From blue to yellow, that's less than 35. I can say those are low flow. So anything higher than 35, like I mentioned, you can categorize them as high flow. Now, one more thing that you need to remember about Venturi mask is this device is actually, remember when I was talking about simple face mask, when I was talking about nasal cannula, we mentioned that here in the atmosphere can reduce the concentration of oxygen we are giving to patients. But simple face mask, this device is actually don't forget, I mentioned that this simple face mask is actually designed for COPD patients. Now, so that means why is it designed for, how is it designed for a COPD patient? You are trying to regulate the amount of oxygen you are giving a COPD. You don't want to overdose somebody that have a chance to retain CO2, if that makes sense. So for a Venturi mask now, so the amount of oxygen, the concentration of oxygen we are giving to a patient is well regulated. It's very, very regulated. That's what we are saying here. So now, so this design, yeah, I mean, this Venturi mask is designed in a way that normally it's going to allow some room here to be entrained in these things, yeah, in this orifice. Let me show you from here. It's going to allow some room here to be entrained in this orifice. Now, you are giving 100% oxygen coming from the tank. Now, that 100% oxygen is going to mix with the room here, the amount of room here that has entrained in this device, yeah. Then if I'm giving blue now, for example, now, then 24%, certain 24% is going to go to my patient. That's how it works. If I'm giving somebody a white, let's say I'm using white now. So for white, for example, so my patient is likely to be getting 28% concentrations of oxygen, FiO2. That's how it works, yeah. I hope you are getting these things. So now, aside from that, let me also say something here that, so the liters that you need to set to be driving these things are also ratings on this device. Like I mentioned, do not cram it. You don't have to cram it. For example, now, for blue now, it could be 2 liters. For white, you find it on it, the fraction will be there, the liters you need to use to power that thing will be there. Now, how about now? Let's say now I'm at the bedside. I've gone to see my patient. This patient is on blue color of Venturi mask. So now, the blue color of Venturi mask, normally you need 2 liters to power that. And that should be giving around 24% concentrations of oxygen from the tank. Now, and I now find this patient on, let's say, rather than 2, my patient is now on 5 liters of oxygen. So what do we think, physios? One person, please, what do we think? Do you think this patient will still be getting the same amount of oxygen that they should be getting? Do you think they will still be getting to 24% they should be getting, or they will be getting less? What do you think? Now, this person is meant to be on 2 liters, and let's imagine this person is now on 1 liter of oxygen. Do you still think this person will still be able to be getting 24% of oxygen? Please, I just need one person to talk. What do we think? What do we think, physios?
No, sir.
Okay. For which one? For high amount, for high liters or for low liter? Which one?
That's for low liters, the percentage will be lower. Okay. Then when it's high, I guess the percentage would also be higher.
Okay. Can you just give maybe brief explanation to that so that we can understand that?
Okay, like
because
you said,
things, sorry, one sec. Because these are things we see on the ward. You go to see a patient, they are on, let's say, blue. They should be on 2 liters. You see the nurse, they bring it up to 5 liters, and we are wondering, but what's going on here? But so because these are real things we'll be seeing on the ward. So what do you think? Yeah, yes, ma, go on. Sorry.
Okay, what I feel is, since if 2 is supposed to, maybe the person is supposed to get like 24%, and they are now giving the person 5 liters. So maybe the 5 liters, the percentage would increase maybe to, let's say, maybe 30.
Okay.
That's what I think. That's what I'm just
yeah. There's no right, like I always say, there is no right, there is no wrong. Yeah, I appreciate that. Thank you very much. Yeah, for low liter, let me go. You are supposed to be on 2 liters. Now you are on 1 liter. What does that mean? There is little amount coming from your tank. The room here is also there to dilute that oxygen for you. Definitely the fraction you'll be getting, your patient, the concentration of oxygen your patient will be getting will go low. Simple. Now, you are meant to be on 2 liters. You are on 3, 4, 5 liters, for example, now. What does that mean? You have more concentration coming from the tank. And you have the room here and also diluting your oxygen. Yeah? Now, the idea here is this. It's a bit different, but I won't want to start talking about Bernoulli equations and all of those physics something. Yeah. But yeah, what is likely to happen here in that situation is, because the more concentration of oxygen you've got coming from what's it called now? Coming from the tank, lot of them coming, then you are likely to drive in lot of oxygen, lot of room air oxygen from the atmosphere as well. So now this thing is going to look like balancing each other, like trying to balance up each other. But one thing we need to talk about here is the amount that will be going to your patient is going to be more than when you put them on 2 liters. I don't know if somebody understands these things. So, for example, now let's say, but like, I mean, the total volume of oxygen that will be going to your patient is going to be more than when you put them on 2 liters. Because the flow, you are supposed to be using 2 liters to drive something. You are supposed to be driving a car with 2 persons. Now you are driving with 5 persons. What does that mean? Then the movement will be more. That's what it means here. The concentrations, really, the concentration might still stay the same, because that concentration, the concentration you are given will drive some room here to dilute that. Yeah. But what we have to talk about here is the flow, the total amount of oxygen that your patient will be getting will go higher, if that makes sense. So now, it could have some advantage. It could also have some disadvantage. We need to talk about advantage. Let's say a patient that is actinic or that is breathing very fast at the moment. If you give them high flow, high flow, it could also settle them. But again, if your patient is not like it, they are settled, they are just desaturating, and you are popping them on Venturi mask. Don't forget, you are pumping high volume of oxygen to them. That can also be very uncomfortable for patients. That is what that means. And again, don't forget, this is also dry here. Venturi mask is also dry here. We are not adding water to this thing. It's also dry here, like like a nasal cannula, like a simple face mask. It's also dry here. So remember these things. When you go on the ward and you find somebody they should be on 2 liters, they're on 3 liters. Yeah, just check. How is your patient finding these things? Check. See how they are, see how their breathing is. Then make your decision either to bring it down to 2 liters or either to get them up, either to bring up the oxygen or stay or leave it where it is. So think about those things before you make those decisions for your patient. Now, one thing that I also need to remember, I also need something that is coming to my brain that I also like to talk about here. There's something we call, there's a concept we call peak inspiratory flow. Yeah, peak inspiratory flow is just, now imagine somebody normally now we are all breathing on room here, relax, we are driving in, we are losing around 20 liters per minute to drive in 21 liters of oxygen into our lungs. Imagine somebody that is now breathing very, very fast. They are breathing very, very fast. So in the atmosphere, the energy they will be needing to drive in oxygen is going to be very, very high because they are because now they are desaturating. They are desaturating, so they need their respiratory rate to go very high. So what I'm trying to say, I don't want to complicate these things. What I'm trying to say here is you've got a patient, if their respiratory rate is greater than 30, venturi mask might also struggle with what we've been talking about, nasal cannula or simple face mask, in terms of fraction of oxygen. That's what I'm trying to say here. Let me make it clear. Let me repeat these things. I don't want to complicate these things. If you've got a patient, their respiratory rate is less than 30, what that means is that that venturi mask is likely to meet their peak inspiratory flow. Yeah. Oh, blue, 24%, 2 liters. Yeah, it's likely to be very correct. So now, but if somebody's respiratory rate is really, really very high, so their peak inspiratory flow will really, really very, very high as well. We go very high. So the tendency is there that by the time they breathe very, very fast, so they will be driving in large amount of room here, oxygen in the atmosphere, to dilute the oxygen you are giving to them. That's what I'm trying to say. Let me put it in the context of patients. If I've got, generally speaking, like I explained previously, for venturi mask, we like to pop people that are at risk of type 2 respiratory failure, people that normally breathe very slow, people that we want the oxygen to be between 88 to 92. We normally like to get them on venturi mask. Venturi mask and nasal cannula. We don't want to even go around simple face mask. I have explained that. Now, so in this let's say now you've got 2 patients. One patient, their respiratory rate is less than 30. Another patient, their respiratory rate is greater than 30. The patient that the respiratory rate is less than 30, I might try them with blue, white, yeah, that is fine. But the ones that the respiratory rate is greater than 30, I might be needing high flow venturi to sustain their oxygen. If that makes sense to somebody. So that is that about venturi. What have we set up to now? I've talked about nasal cannula, 1 to 4, simple face mask, 5 to 10. Venturi mask, it could be low flow, it could be high flow. If the respiratory rate is less than 30, you want to think about maybe low flow venturi. If it's greater than 30, you want to start thinking about high flow venturi, if that makes sense to you. Now, I've got a question again for us. On what conditions do we think that let's say I've gone to the ward now, then I'm here to see a patient, and my patient is currently on venturi mask. On what condition do you think I might make the decision to pop them on nasal cannula? Again, another patient. I'm here to see another patient. My patient is on nasal cannula. On what condition do you think I can also put that same patient on venturi mask? Don't forget, if you go back to these things, please respond. If you go back to this picture here on nasal cannula, we said rough estimate, 1 liter can give 28, 2 liters can give, 1 liter can give 24, 2 liters can give 28, right? Now, if you come to low flow venturi as well, blue can give, according to this manufacturer now, blue can give 24% using 2 liters. White can give 28% using 4 liters. Yeah, 28%, 24%. Same thing as 1 and 2 on the nasal cannula. Now, I'm putting this question to you. I've gone to see patient. That means I can sometimes remove nasal cannula, pop patient on venturi mask. I can sometimes remove that low flow venturi, pop patient on nasal cannula. My question is now, on what condition do you think? Because we need to know these things as a physio. Because you will find patients struggling with venturi, and you might want to make the clinical decision to return them to nasal cannula. Same like 1 liter, 1 liter, same fraction now, same estimated fraction you are looking at on nasal cannula and the one you are looking at on low flow venturi. I don't know if we are getting these things. So on what condition do you think I can make the decision to get my patient from nasal cannula to venturi or from venturi to nasal cannula? Please, 2 persons, what do we think? What do we think? Hello?
Sir, can I try?
Please go ahead, ma.
Okay, we can put them on the venturi if we notice that, let's say they are on that nasal, the nasal one, and then we notice they are breathing very fast.
Okay.
So we can now switch to the venturi. Then if they are on the venturi and now we now notice that their respiratory rate is a bit normal. Okay. They don't need that high flow anymore. Then we can now switch to the nasal.
Okay.
Yes.
Okay. Thank you. Yeah, in terms of patient presentations now, let's look at, you have mentioned in terms of, you mentioned in terms of their breathing pattern, which is nice. Yeah, how about, let me just get female response. What do we think, guys? What do we think?
Okay, sir, let me make a contribution.
Yeah, go ahead.
So I would consider escalating or de-escalating either from nasal cannula to, okay, let me talk about moving from venturi mask to nasal cannula. So if I'm looking at the patient has improved oxygenation with the SATs improving, okay? So I would consider de-escalating, that going down to nasal cannula. And also, when I notice that a patient also requires reduced oxygen requirements, okay, I would consider that also. And it also has to do with the work of breathing. Okay, if I've noticed that the patient has reduced work of breathing, that means that patient is less tachypneic, or the patient is not using accessory muscles, and then the chest expansion has improved. Obviously, there's only been high venturi max requirements. I can de-escalate with nasal cannula.
Cool. Good. Yeah, thank you very much for that contribution. But I want us to look at it from this angle. Beyond breathing pattern, beyond these things. Imagine my patient is on white, color-coded venturi mask, which gives 28%. And another patient is on 2 liters of nasal cannula, which we can estimate that they give 28%. You see, 28. My question is now, on what condition can make you think as a physio that I can change that venturi to nasal cannula? I can change that nasal cannula to venturi. That is my question. Yeah, you guys are right. Breathing pattern is escalating them to simple one. Yeah, that's fine. They are good. They are doing well. I'm sorry. They are struggling. Get them on higher ones. That we know their fraction will be more close to accurate. They are doing well. Let's get them on lower ones. Yeah, you guys are right. But beyond that now, I've gone to see a patient. Beyond that now, what do we think? One more person, then I have my opinion. So one more, please speak, because these are real things we're going to be seeing on the world. Yeah. And we know that we have autonomy to change. We have autonomy to titrate. We have autonomy to win. So if we'll be doing all of these things, we need to have good clinical reasons. And those things need to be going into your note. Clinical decisions to swap, simple venturi mask, 28%. And how do we document venturi mask? We document using fractions. 28% FiO2. Simple, like I mentioned, simple face mask, nasal cannula, use the liter, because we are not very sure about their FiO2, if that makes sense. But the FiO2 of venturi, we can be very, very sure. To some extent, we can say, okay, 28% FiO2 of venturi mask. If that makes sense to somebody, then put their saturation, the SpO2 of 92, SpO2 of 90, SpO2 of clinical, like that. If that makes sense. Yeah. So what do you think, guys? Without wasting time, maybe I should go for my opinion. So what that means is, for example, now, imagine somebody, maybe they've got a nasal block. So what you'll be seeing on the ward. Let's say they've got nasal secretions now. Their nursery is blocked due to any reasons. Yeah, and they are still, at the moment, they are requiring very low oxygen. Do you still want to keep popping nasal cannula through their nose? Think about that. Why not going for something that will cover the nose and the mouth? You can think about mask. But if you've got some confused patient, imagine the other patient, the gentleman on in the hospital, from our case scenario that is confused. How are you so sure that if you pop Venturi mask on the face of that man, the man will tolerate that Venturi mask? The man will not keep dragging and removing the Venturi mask. Why not try something that is tiny something that can just go through their nostrils for compliance? Think about those things. So in that regard, clinical reasoning is not about stuff. It's not stuff. It's just what you can reason at their bedside, and you're going to make big change in their life. We know this gentleman that is confused. He needs oxygen. If he doesn't get that oxygen, he's going to die. If we keep desaturating, he's going to die. But at the same time, if you pop him mad, the chance is there that does not still mean for every confused patient they cannot tolerate mad. But clinical reasoning now, generally we are talking here. Now, if you pop him mad, this man might be, at the moment, this man might be agitating, hallucinating, even dragging the mask. Because have you talked about from people that are normal, even that they are not confused, they are claustrophobic, that are very, like, people, when you pop in mask, they be like, you want to take life out of them. Just go for something lesser, something that will facilitate compliance. That makes sense to us. How about this again? Have you thought about patients that are mouth breathers? These are clinical reasonings. Mouth breathers, like they breathe through their mouth. If you give them nasal cannula, do you think that will be very effective? What the breathing they are doing through their mouth is going to do a lot of dilution to the oxygen percent that you are giving to them, to the oxygen you are giving to them. Do you still want to continue to use nasal cannula for them? It will be effective. So what do you want to do? Oh, you can say to the nurse, oh, this person is a mouth breather. He breathes through the mouth a lot. Just remove this. Let's remove the nasal cannula. Let's use simple face mask. So why not? Because with simple face mask, cover the nose and the mouth. Let's get them to breathe through the mouth as well. And again, clinical reasonings. If they are type 1, the oxygen saturation, the target stat is something above 95. I can get them on simple face mask. I can get them on Venturi mask. But if it is patient, that means Venturi can be used for either type 1 or type 2. That's what we are saying. But yeah, but simple face mask, if they are mentioned in the note that, their target stat of they are on scale 2, 88 to 92. Do you want to put them on simple face mask? No, because with that simple face mask, you are putting them at risk of retaining CO2 at hypercapnic respiratory failure. If that makes sense to somebody, please, do we understand these things, please? Please, reactions, please. Does it make sense? Do you get the explanations? I'm just trying to keep it low. I don't want to be speaking a lot of physiology, but let's say something that is practical. Yeah, is it making sense, please?
Yes, sir.
All right, let's move on. Cool, thank you very much. Thank you for the reaction. So we have talked about Venturi mask. So now, humidification circuit. Of course, before we think about humidification, like I mentioned initially, think about it. Your patient, there must be evidence of secretion retention. And now maybe the oxygen requirement now is now going ahead of low flow Venturi, maybe more than 4 liters of nasal cannula. Because with 4 liters, 2 liters of nasal cannula, I can just tell the nurse, just do regular nebulizers, give them regular nebulizers. And me as a physio, what am I doing from their chest? I'm doing my chest stuff with them. I'm getting them up, getting them moving at the same time to increase their functional residual capacity. I don't want to start talking about those things now. Yeah, they start doing your stuff. But now, let's say the oxygen requirement now is now going beyond 4 liters, 28 what's it called now? 28% or so. So they are now it's going beyond 4 liters, 36%, something like that. So what do you want to do? You can now start thinking about, let's get bubble bottle for them. Let's get them on Aqua Pack. Aqua Pack is, depending on where you work, you might find this Aqua Pack. Aqua Pack can give concentration of oxygen from 28% to around 80, 90%. And one thing again I need to say, when it comes to research, this humidification here, this Aqua Pack or humidified circuit, because these are cold, of course, the water you're going to be using here, they are saline water, they are cold humidification. They are not hot humidification. They are not damp humidification. They are just cold humidification. But what research says is these things there is no evidence for it that they work. That's what I'm trying to say here. But by clinical practice, I can say to you as a respiratory physician that this thing works. this is why you keep finding these things, even in anywhere in the world, you still find these things, people still use it. But what research says is this thing is very big. But clinical practice, it works. That's where you still find it everywhere, even in anywhere in the world, you still find these things. Yeah. So now, and again, Aquapack, very noisy device, makes a lot of noise. As a person, I don't really like it. It makes load of noise. But what is the benefit to your patient? It's going to moisturize the ear. Remember, there's something we call mucociliary escalators. Big language, simple concept. These are like early structures that are in your lungs. What do these structures, what do they do? I think they work with liquids, semi-liquids, soil gel layers that they keep swiping your lungs. Ciliary, they keep cleaning your lungs. So those layers, they work with moist environments. So if your patient is on venturi mat for longer period of time, dry oxygen, it's going to dry their throat, it's going to dry their airway. And these are people that are not, let's say they are not drinking, they are not eating well, they are not even doing those things well. What is going to happen? So their airway will start getting drying off. And from there, bacteria can start going in their chest. Even aside from that, before you know, they will start struggling to cough off phlegm in their chest. Because now in their chest, their mucociliary activity will be down. That escalator activity will be down because they like working in a moist environment. But by the time you start blasting somebody with too long for dry oxygen, your ear will start drying out. That is why you now start thinking about, oh, let's get them on Aquapack. And if they are not this device and you know that they are really, really struggling with secretion, they are struggling to cover up secretion, get humidification as well. Get the doctor to prescribe nebulizer. Tell them, I need hypotonic nerves. Get them on 6%, 70%. You tell them these prescriptions. And I don't know how it works now, but these are knowledge we need to start thinking about how we can hone our ground and we start doing our job as it should be done, honestly. Because these people are not dealing with secretions. Physios, you are this one dealing with secretions. If I'm with the patient side and I'm chankering them or I'm junctioning them or I'm doing any other techniques with them, and I'm looking at their secretion loads and I see it's very thick, doctor will not do these things. So who should be telling you some of the stuff they will be needing to soften their secretion? It is me that is dealing with their secretions. It's as simple as that. Yeah. So anyways, you can also tell them some other things combined with carbon-16 if they need them. Mucolytic agent to further soften their secretions. Anyway, this you'll find in some hospitals, you'll find this device. Don't let us go too far. And again, another thing, but like I mentioned about evidence does not really say this thing really works, but clinical expertise shows they work. And aside from that, what evidence actually suggests is when your patient is on this thing for longer period of time too, bacteria start going in this bottle, your patient might start developing chest infection. Just be aware as a physio as well. All right, you can also find this one as well in some hospitals. I see not showing very well. In some hospitals, you can find humidified circuit as well. Same thing, if your patient is now standing chesty, they need humidified oxygen, so get them on humidified circuit as well. So non-rebreathe, let's move forward because of time. Non-rebreathe, I think I've got that one here. Let me show you. If you look onto the screen, this is non-rebreathe mask. So this bag here, this bag is just 1 liter. That's what this bag is. So generally you'll find these things in emergency situations. Let's say my patient is desaturating now. I need to top up their oxygen. So you'll find this thing at their bedside. Now, how does this thing work? For example, now of course these things will get connected here. Please, can you guys see these things? Hello? Are we still here? Are we still saturating? Are we saturating? Are we here,
Yes.
please?
Yes, we are.
Good. Yeah. So connect this thing here. This one goes to the oxygen tank. Now, if I need to, of course, oxygen need to fill this thing first before I blast my patient with these things. So the first thing, there is a device here. So what this device does is, generally speaking, when your patient breathing, of course, they must breathe out. They breathe out CO2. So the structure here, this thing closes, this valve here closes on expiration. So it does. So what that means is your patient CO2 does not enter into this bag on expiration, which makes sense because we don't want our patient to start breathing back. CO2, we breathe out CO2. By the time they start breathing back, by the time CO2 start entering into this bag, the chance is there that they start breathing CO2. They start taking in CO2 again, something the waste product they should be breathing out. Now they start consuming it again. That does not make sense. Now, if I need to blast my patient on these things, what do I need to do? I've connected this thing to the oxygen tank. You need to pop your thumb on these things. You need this bag to fill up first before you blast this thing. That is how it works. Before you blast this thing on your patient, if that makes sense to you. So that's the, and again, let me say this thing again. Generally, when you find patients on non-rebreathe in the hospitals, and again, in case of emergency, that does not still mean I must always start with this one, first of all. You might start progressively. It depends on the rate of desaturations. That will determine, oh, do I need to just first go for non-rebreathe before I go for some other ones, before I start bringing them down. You can go first and you start bringing them down, or you progress. 1 liter nasal cannula, 2 liter, 3 liter, not saturating, 4 liter, not saturating. Go to simple face mask if they are type 1, 5, 6, 7, 8, not saturated. Then think about this one. Pop them on this thing. So now what this one does is you go on to 15 liters. It works best with 10 to 15 liters. If you go on to 15, don't forget nasal cannula, 4 liters, simple face mask, 10 liters, highest you can go. But for this one, venturi mask, you can still go up to 15 liters on venturi mask, right? But this one works really, really very fast in case of emergency. So this one, 15 liters. And this 15 liters will give you around saturations close to around 85, 60 to 90% saturations. Between 60 to 90, 55 to 90. You know, these are estimated stuff, because again, why are we not very sure about that amount of FiO2 we are giving you, even with this one? Why we are not very sure is because your breathing pattern of your patient can still influence the amount of oxygen they are getting. Don't forget, here in the atmosphere, if I pop this one on my face now, if you guys have a look at me, if I pop this one on my face, here can still come in here, here can come in here can still get mixed. Here can still get mixed. Because this thing open on inspiration, here can still open, atmospheric air can still go into this and dilute the oxygen. That's why we are not very sure. But we know the estimated value can be between, don't cram this thing, you don't even have to remember it. In practice, generally speaking, you don't have to remember it. So now, so that's how it works. So, and again, another thing that we really need to talk about in nasal cannula is when you see patients that are on this non-nasal cannula, when you see patients that are on this non-rebreathe, and we are struggling to win, MDT is struggling to win down their oxygen, and their respiratory rate keep going at 20, 25, 30, and they are breathing heavily. And even with non-rebreathe, they are saturating. They are meant to be greater than 94, 95. They are saturating 92, dropping down 89, 93, dropping down 90. These things. Yeah. What does that mean? Because on the ward, the max we want to start going when it comes to giving somebody oxygen is 15 liters on the ward. What does that mean is, people will start making plans. Oh, I think they're going to need treatment escalations to another device that can offload their breathing, because their breathing pattern is really, really crazy at the moment. If we don't control that breathing pattern, what will happen to them? At some point, they will get fatigued. And when your patient gets fatigue, physios, what does that say to you? Their ventilation is getting reduced. What does that mean? Your patient can start going into, they can start feeling drowsy, they can start retaining CO2. Before you know, CO2 will start driving their breathing, their pH will start dropping down. I'm going to talk about blood gas. When their pH starts dropping down, they can start, they can even go into respiratory, they can start having a lot of headaches, more drowsiness, more confusions. Some can even go into respiratory failure. So now, because we don't want that to happen to our patients, so what do you think? People will start making plans. You find ITU doctor, consultants, you find critical outreach team. I don't know if we've got them in Nigeria. You find people that can escalate patients. That's what I'm trying to say. Then you find physios. People say, if physio is not there, they'll start shouting, where is the physios? Can physio do something here? Escalate. Because there is a care, there is ceiling of care. There's something we call ceiling of care. There's ceiling 1, 2, and like that. So what based care? There is ITU-based care. For example, now, you have to tick the box. Where is physio? To let you know. And in this regard, sometimes when you go walk in and you go see some of these patients, it might just be maybe they are really, really struggling with mucus plugging their airway. And when you do your stuff with them, they might even get better. They might not even need to be intubated and be ventilated. They might not even need that NIV that people have been suggesting to them. That's why people will say physios. And sometimes when you come around to some patients, you look at them, their respiratory is really, really very high. Some of them might even be confused. They cannot even cycle with your cough assist or whatever you want to do with them. Secretion might not even be their problem. That is another thing. Secretion might not, but we need a good clinical reasoning to be able to judge what is going on with this patient. Is it secretion retention? Is it lung collapse? Because generally, for respiratory, what do you treat? You treat sputum retention, you treat loss of lung volume, you treat increased work of breathing, and then these are stuff you are treating with your patient. So now, if all these things are not there, you can make the judgment that this patient is not for me. And what advice? Or let's say you are even the first person seeing this patient. What advice? Who do you want to speak with? You want to start speaking to the consultant. Oh, and I think at this point, I'm really short of treatment approach. This patient here, their respiratory rate is really very high, and this is not physio amendable stuff. So I think they might be needing escalation plan. They might be needing escalation of treatment plan. Do they need NIV? Don't talk, because there are a lot of medical reasons that can actually make somebody to be having that respiratory distress at that particular time. You don't want to be very affirmative. Yeah, this is the issue. Get them on this thing. Get them on NIV. No, you want to make like an assumption. This is how people will respect you. This is how people will know that you are not forcing things on them. But that might not really, what you are thinking might not really be. There are millions of things that could drive that breathing pattern of that particular patient at that moment. That's what I'm saying. So you want to just say to them, oh, could they be needing maybe NIV to offload their breathing pattern, BiPAP, no? Or would they be needing CPAP to support their oxygen? So these are what you want to be saying to them. Yeah, because you can say, yeah, this is because I'm just, the current situation is not something I can amend. It's not physio amendable. So what do you think? And they will get them. And again, that's now they escalate. They get them on CPAP. They get them. You will still continue your stuff with them if you've got evidence. If you've got sec retentions, they've got lung volume, you continue your stuff with them. Even if it is your patient in the first place, their respiratory rate is not getting settled, their breathing pattern is not getting settled, they are not saturating, they are still desaturating, and you are still doing your stuff. You can still escalate that part, and you continue your treatment plan when they are on that appropriate device that can support their breathing. You continue your treatment. So these are just to tell us the importance of physios. We are very important, and nobody can replace you if you are not doing your job. Now let's bring it back home now. In some of those things we are supposed to be doing that we are not doing, what happens to our patients? My greatest concern is just the patient. So that is why we are here today, and that's why we are doing all of these things. Anyways, let's move forward. I have explained these things. Place your thumb on it, fill the bag for us, then blast the oxygen on your patient. I have explained this. Flow. This is one of the devices. If somebody is struggling with this, one of the devices, one sec, please. Sorry. If somebody is struggling with let's say non-rebreath now, for example, they are not being saturated, one of those things you can get them on is this flow here, optic flow. This is FO. Generally on the ward, you might not find this on the ward. You might need to go into ITU settings or HDU, high dependency area, before you find some of these things. But on some wards, like patients that we know after their surgery now, they can be really very chesty. They need humidified oxygen to be compatible with life, because if their airway gets dried, there might be issue. You can start thinking about maybe head and neck, somebody with tracheostomies, laryngectomy. You will find these things on their ward. You will find it on what do you call it now? ENT wards, head and neck wards. Generally, let somebody have got tracheostomy now. So normally, like we've been explaining, we want our airway to be moisturized. Do you want to start blasting them on dry oxygen? No, you need something like this to humidify their oxygen. And generally, these things, it got a lot of advantage. So this one can give liters. You can go as high as between 50 to 60 liters of oxygen on these. You can drive oxygen to the patient with up to like 50 to 60 liters, compared to all these ones that are just 15. On what base level you want to just keep it on 15. That means the amount of oxygen, the concentration of oxygen you want to give to patient on what base level should not be more than 60, something like that. But for high flow, patients that are struggling, you can still give them up to 50, 60 liters. That means if you are giving somebody 50, 60 liters now, the amount of concentration of oxygen you can give to that person might be around close to 100, 95, 98%, close to 100, something like that, if that makes sense. So there are a lot of advantages to this. It gives moisturized oxygen. It gives humidified oxygen. Now, let me say this again. If you really want to give a patient definite amount of concentration of oxygen, you have to start thinking about optic flow, eye flow, air flow, something like that. You have to start thinking about this. Now, this thing does a lot. There are a lot of researches out there that talk about the advantages of these things. I will not go in detail. One of the advantages, for every 10 liter flow to a patient, it gives around 1 centimeter of PEEP. What does PEEP mean? I don't want to talk about a lot of physiology. I don't want to complicate this thing. What does PEEP mean? PEEP is, let me see how I can explain this. PEEP is just, of course, what it means is positive end expiratory pressure. If I ask you guys now to take in deep breath, breathe out, deep breath, breathe out, what are you doing? You are just doing normal tidal volume, breathing in, breathing out, breathing in, breathing out, like what everyone have been doing so far now, breathing in, breathing out. No issue. Now, if I ask you breathe out now, taking deep breath, long one. Now I'm taking a very, very long breath out. You can say, now that long breath out that you've just done, what you've just done is you've just done, what do you call it? End expiratory reserve volume, ERV, the breath, expiratory reserve volume. Now, if you breathe out, no matter the energy you've got, no matter the reserve you've got, and you start breathing out, there is this amount of oxygen you will never get out of your lungs. Let me say this thing again. If we remove somebody's chest, God forbid, and we bring out somebody's oxygen and we put it on the table. Now, there will always be that amount of oxygen in the lungs. The oxygen will not be collapsed. Like, no, for a surgeon or for us to remove somebody, to open somebody's chest and remove their lungs, let's imagine the person is dead already. So we expect normal thinking, we should be expecting the lungs to be collapsed now, not to be inflated. Now, if you remove that lungs and you pop it on the table, the lungs will still be slightly inflated. There's something that is making it to be slightly inflated. I give you another example. If I give you a balloon and you start blowing, you know at the start, it's going to be very difficult for you to inflate at the start. But at some point, the thing will start getting easy for you to inflate, to continue to fully inflate the balloon. Now, initially, the amount of air you pop in, that difficult air that you pop in, that air is called residual volume. When we remove somebody's lung, and we pop it on the table, the volume in that lung that does not make the lung to collapse is what we call residual volume. Now, that residual volume plus the air you blow out, no matter your energy. Now, that residual volume, let me repeat, that residual volume is the lung that you normally have in your lung at the end of every, not like that. Now, that residual volume is the volume that prevents your lungs from collapsing. That is what we are saying here. Now, that expiratory reserve volume, the one you blow out, that long breath, plus the one you normally have in your lungs, that prevents your lung from collapsing. If you add two of them together, they will give you FRC. I know I'm saying a lot of nonsense here. They will give you FRC. What's the meaning of FRC? FRC is called functional residual capacity. That, of course, when you add volume to volume, they're going to give you capacity. That functional residual capacity here is normally in your lungs. Now, when it's normally in your lungs every time, that prevents your lung, what we say in clinical practice is FRC, they splint your airway. That residual volume, again, that you've got is not enough to prevent collapse in your lung. You need something on top of that. So if you do a very long breath out, the air at the end of expirations, the capacity that you've got is called functional residual capacity. What's the importance of that? The importance of that is just to prevent collapse. It's just to give a large surface area for oxygen to diffuse. You just forget about that nonsense for now, but what you just need to remember is high flow, they are humidified oxygen. Another thing they do is they can give large amount of oxygen. Just remember that. Even if you don't understand the rubbish physiology that I just explained, just remember that. And high flow, if somebody is struggling, if we really want to humidify somebody, think about high flow. If you really want to get that concentration of oxygen, think about high flow. If that makes sense to us. Special note, like I mentioned, you find this on ENT watch, tracheostomy, larynectomy, because you want to humidify the airway as well. And again, this is warm humidification compared to the cold humidification. Now, evidence really support these things. Hello, sir. Hello. So evidence really support this one compared to your aqua pack, compared to your humidified oxygen. Let me show you some pictures here. Yeah, this is one of them. Look at this picture here. If I want to know, I'm on the ward now, I want to know what amount of oxygen is my patient. What is the concentration? FiO2 is the concentration of oxygen that my patient is getting. I will just press this play button here. If you press this play button, it's going to bring this screen for you. You will see the liter. You can see the liter here, 20 liters. So they are using 20 liters to drive. It's going to bring the FiO2. It's not very clear here. It's going to bring the FiO2. And it's going to bring the temperature. Why the temperature? Temperature that will tell you the amount of humidification that your patient is getting. Don't be worried about any other thing here. The nursing staff, they are well trained to control these things. You as a physio, just go there. I want to check what this thing is. I will just press this play button here. It's as simple as that. That does not still mean if you are competent as a physio, you can still control the apparatus. But basic things, press this play button. It gives you the liter, it gives you the concentration, it gives you the temperature. If that makes sense. Look at this now. If I now need, let's say my patient now, don't forget this is on 20 liter now. 20 flow, 20 liter per minute. That's the flow now. Let's say the FiO2 here is, let's say 60%, and my patient is desaturating, and I want to increase the oxygen. What am I going to do? I'll just go to the wall, just increase. Let's say this one is 1, 2, 3. This is 3 now. This is on 4. Sorry. What am I going to do? I will just turn up this. I'll bring it to 5. I don't have to be worried about other parameters here. What I will just do is I will just bring this on to 5. Just take it up. So the machine on its own will control the FiO2 that will match the new liter you have set. If that makes sense to somebody. I know these are practical stuff, honestly. They are not best taught in classrooms. So we see what we can do regarding the practical. But for now, just have some basics. We move forward. So this is just explanations to what I just explained. So now, how do we measure oxygen saturation? What have we learned up to this moment? What have we learned? Nasal cannula, somebody desaturating 1 to 4, simple sleep 5 to 10. Venturi mask, different color, very good for somebody on scale 2, somebody that can retain CO2. And again, for low Venturi mask, for low oxygen device Venturi mask, I can swap between Venturi and nasal cannula if there is need to do it, if that makes sense to you. And again, how do you check oxygen saturation? You can check on fingers. You can check using somebody's ear. You can check. And again, please be careful here. There are a lot of hazard. Clinicians on the ward, they have caused to patients. The probe you are meant to be using on the finger, you are trying it on somebody's ear, and you are causing pressure damage. That is not good. That is not good. So now think about that. And aside from that, another question for us, guys. What condition will make you as a physio to consider checking saturations using patient ear, rather than using their fingers or using their toes? What conditions? What do you think? Like, what will make you? Because these are basic things we need to know. Yeah, 2 persons. What do we think? Please, time is going. What do we think? Please, speak up. Speak up.
Good evening. I think maybe if we have maybe an amputee patient or something like that, we could use the ear for the probe.
Perfect. Is it upper limb amputations or lower limb amputations? Which one?
I think both, but if maybe upper limbs, because some in my practice, sometimes I think the fingers will give you a almost more accurate situation. So maybe upper limb.
Okay.
Upper limb amputations.
Yeah, good clinical reasoning. Thank you very much for that. Yeah, if they are amputees, yeah, you can try it in there. Yeah, that's fine. Yeah. Who is there? Speak up, please. What do you think?
I would consider that if the patient has poor peripheral precision, okay?
Sorry, if they've got peripheral,
poor peripheral precision, like cold hands, or a patient that is having currently shock.
Yeah, cool.
Or maybe peripheral vasoconstrictions.
Yeah.
So I think the ear would be a perfect, better to give us a central precision.
Yeah, good, perfect, lovely. And what condition comes to mind when we talk about maybe cold hands, cold this, cold finger? Yeah, what certain condition comes to mind generally? When you just see it in their clinic, in the past medical quiz, you're thinking, maybe I start checking from their ear or something like I don't know. Yeah. Sorry, I can't hear that.
Conditions like hypovolemic shock.
Yeah.
Or even the COPD patient.
Yeah. Some COPD can be hypoperfused. Yeah. Cool. Perfect. Yeah.
And Raynaud's disease.
Raynaud's disease. Perfect. That is, yeah. Perfect. Excellent. Thank you for that. Yeah. Raynaud's disease. Yeah. Think about it. When you say it normal, I'll just say, yeah. That does not mean I cannot try their finger first. But in my head, I know, I need to be sourcing from SPA. Yeah. Perfect. Good. Lovely. Good clinicians. Yeah. So let's move forward. So that is that about these things. And in assessing your patients, I'm not going to sit down with this today and talk about these things, what we need to be doing well in terms of, because respiratory competence is what acute physios, if not everybody, at least because there is ward-based care, there is ITU care, at least for seeing acutely patient in an acute hospital, you should be able to do some maneuvering about oxygen and stuff. So we should have this competence to be able to control oxygen anyway. Now, how do we generally assess? As opposed to our general conventional way of assessing, maybe let's say respiratory now generally, that we do what do we call it, systematic head to neck, head and neck, chest, neurology. There is a simple way, head to ear approach. This is worldwide something. This is it's very simple. I'm not going to talk about that today. Very, very simple stuff. So in the breathing, A, B, C, D, E, like that. B is the breathing there. In the breathing, you want to talk about in your assessment what influenced that oxygen. You want to blast them on oxygen. You want to write, this is their baseline, maybe resting saturations, this is their current saturations, or what oxygen device did you meet? Oh, they are on 2 liters of oxygen, 2 liters of nasal spec, saturating with this. Then in your so all those things should be coming under the breathing. Just for now, just brief things for now. I'm not going to talk about every other part for now. So of that A to E assessments, but those things should be coming under your breathing. Forget about the assessment part now. For now, we talk about assessing patients the next time. Okay, all right. Can you identify this stuff? Physios, open your mic. What is this? This first man, this gentleman, lovely man, well settled. Yeah. What device is this man on? You are just going on the wards. You find patient on this, or maybe somewhere else now. So yeah. First one. What device is this? Hello? Hello? Let me just check the chat. Sorry, sir. What is this first one here? What is this first one? It's going through the nose. Then it should be what?
Nasal cannula.
Nasal cannula. Yeah, ideally it should be nasal cannula. But if you look at this is like thickened structure now. More than normal tiny things you would normally find in the nose. Yeah, this is cannula. But what cannula? This is high flow nasal cannula. High flow nasal cannula here. This is high flow nasal cannula. This gentleman is on high flow nasal cannula. The one we say he can give up to 50, 60 liters. That is what this man is on. Now, this picture here, this is another common picture. Yeah. What is this? This is also still high flow as well. Again, this is high flow again. Yeah. This is high flow. You move for this, you might, and then FMP, this thing. This is also high flow. Don't worry. We're going to do a lot of stuff later. Now, come to this one, the third one. What is this? Of course, we are familiar with this one. What is this one here? Please open your mic. The last one. What is this? Please open your mic. Pop the response in the chat box. What is the last one? Hello? What is this last one here? Oh, nobody is responding. Of course, you can see. What can you see in the last one?
Oxygen flow meter, humidifier bottle, then oxygen cylinder.
Cool, that's it. You've got cylinder, you've got flow meter, you've got a bottle, And now what do we think this oxygen is likely to be doing, or what, like clinical reasoning now generally, what do we think is likely? Why is this patient having this bottle of water here? What do we think? What sense can we make of these physios?
Oh. Yeah.
For humidification, most likely.
Humidification. That's it. Simple as that. Humidification. That's it. That's it. Yeah. And one thing I forgot to tell you guys when I was talking about that bubble aqua pack the other time, you want the length of that this thing to be shorter as much as possible, because you know if it is longer, you might start having water inside the tube. If that makes sense, this is sometimes when you go on the ward and you find water there, you know that is going to affect the oxygen concentration your patient will get. You can cut the tube. You will want it to be between 1 to 1 liter, 1.5 liters. You can even cut the tube if you have the. These are stuff. That's why I said these are competency. Somebody, let's say a doctor, another clinician, set up patient on that. I know it's going to be a difficult one for us in Nigeria anyways. I don't know, but we need to start thinking about doing the right. Even if you cannot directly do it, say to know, oh, that is fluid. However, if you just remove the tube and you just drain the fluid and you connect it back, how about that? Even if you cannot change it, even if you cannot do it. So we need to start thinking about all of these things. So these are small things we can do that can impact our patient's life. Anyways, move forward. I'm not going to talk about oxygen cylinder today. I will leave that one because we need to now to connect it. There are different versions of portable oxygen. I just brought this one, but I'm not going to talk about it. Let's talk about winning now. Let's talk about winning. Now, like we have mentioned to ourselves that we do have the autonomy to titrate oxygen. We need to be looking at their set targets, the target saturation they've set for the patient. You can titrate, you can wean the patient off. And while you are doing all of these things, you need to be checking their SpO2. We need to be checking their SpO2. You have autonomy to be doing this, but I'm generally worldwide, what standard I'm talking now. Now, and again, let me say this again. If you need to wean a patient, let's say they are on 4 liters or they are on 4 liters of oxygen now, for example, and they are saturating at their target sat is between, let's say, 95 to 98, for example, and they are saturated at 97, 98, or even 100. Our physios, do you want to continue to leave them on oxygen? Remember, when patients do not need oxygen, washing them with oxygen, you should keep blasting them with oxygen. Rebound hypoxemia. Remember that time. Because if you continue to keep them on oxygen, their body will now start adapting to oxygen. By the time you now want to start winning the oxygen, it becomes problematic. And again, you are wasting property. You are causing more cost to patients. And again, you can even be endangering the life of that particular patient. Everybody on the ward should be involved in this, not just nurses, not just doctors. We need to be doing that as well. So what do you want to do here? I want to start bringing it down. Now, from 4 liters, will I just jump from 4 liters and just remove the nasal cannula from their nose? That does not make sense. So what evidence is, or what protocols normally say is we need between 1 to 2. I can go from 4 to 3. From 4 to 2, I will watch them. I will watch. Their probe is there. I will watch them. Are they saturating? Are they still struggling? What is their respiration? What for signs of hypoxemia? Why you're also checking their distance? So watch out for those things. And again, let's say I have successfully bring it down from 4 to 2, or maybe from 2 to nothing now. My patient is on room here. What am I supposed to be doing as a patient? Now I will not just now from 2 to nothing now. Just thank you. Yeah, see you next time. Thank you for working with me. Yeah, see you next time. Just work out. No, my role is again watch them for 5 minutes. Watch your patient for 5 minutes. What are you watching for? Keep that probe on their finger, oximeter on their finger, and again watch them. Watch for signs of saturations. Watch for those things. Watch if they are now struggling to talk, to complete statements. Like it could leave me that now their work ability that started going up, or they are struggling with shortness of breath. Watch out for those minor things. And again, after 5 minutes, they are still maintaining that they are fine. What next do I do? my role, my job role is as a good clinician that keep patient at the heart of everything you are doing. Go and speak with the nurse. Nurse, oh, I just win them oxygen. I just bring them on oxygen. Do you even know that sometimes it's even possible that this particular patient body has been struggling to win them? You physios, you just do your stuff with them. You mobilize them. You get them oxygen. You mobilize them. You do your stuff. You do your case. Just get and just with their oxygen, and they'll be fine. And when you even go tell the next they'll say, "Wow, you are a magician." These are stuff. And again, what have you done? Not the wow that nobody will give you that really matters to you. You have impacted life. You have impacted life. So after you've done your winning, what do you want to do again? Or you've done your titration, speak with the nurse. Oh, I just titrated the oxygen from this to this, or I just win them off oxygen now. Now, the nurses are the ones that will always be with them. They can watch out, they can keep watching. And again, generally what the recommendation is, even after winning, still come back after 1 hour. Generally, that is the standard. That is what the recommendations say. But because you've got somebody watching over them, you might not really, and you've got a lot of caseloads or everything to do, but just get somebody to watch over them. Maybe for about 1 hour. See how they are made. Because after 5 minutes, 10 minutes, 15 minutes, 30 minutes, somebody can still desaturate. But if you need to check back after 1 hour, nurses need to also, if you've got the time, nurses need to also be watching over them. And again, for us to now say, yeah, this person has successfully been weaned from 4 to nothing. Now that will be they can maintain that side for 5 hours, between 4 to 8 hours. That's when we can say, oh, now, yeah, we are successful with somebody from Venturi to nasal cannula, or from 60% humidify to maybe 40%. If that makes sense to somebody. All right. Are we still saturating? Are we still here? Or we are getting overloads, or what do we think?
Yeah, we're here. Thank you so much.
Perfect. Thank you. Yeah. So that's that. So this slide is just explaining what I just mentioned now. Just explaining what I just mentioned. Then citations now, of course, see the same thing. And again, physios, junior physios, your patient is desaturating, maybe greater than expected. Let's say their target SAT is 88 to 92 now, and they are now on less than 3 to 88. Oh, you can be like, oh, we need to speak with the medical team. Even if they are not, even if they are struggling to win them, even if they are not less than 3 or greater than 3, something, we need to be speaking with the doctors every time you do stuff with them. Either your treatment is successful or it's not successful, you need to speak to them because they are also speaking with you. They need to be speaking with you as a physio. Doctor will say, physios, I have a patient is desaturating. You cannot be going on the corridor. They will discuss patient matter. But for somebody to believe in you, to have that confidence in you, you need to have the knowledge that can match them because they believe in you. You need to match them. Many a time, let me tell you this, many a time in the middle of the night, they will call you and say, oh, we've got a patient there, 80% oxygen. We are worried that the oxygen can keep going up and rise to 100. After 100, what else can you give to somebody? That's the end. In fact, you can even go and see somebody on 90 physios. You can even be the saving ground for that patient and you start bringing the oxygen down 90, 80, 70, 60, lot when you do your stuff with them. You see, of course, those patients might need to be in the ITU anyway. Anything greater than 60, any oxygen requirement greater than 60, we want those patients to be maybe 60, 70, they need to be in the ITU. Because some of them might be needing high support of oxygen, they might be needing high flow, they might even be needing to be intubated and ventilated. Don't worry about those things for now. I'm going to give us some basic tips about all of those things. But what I'm saying in the real sense is physios, we make a real difference when it comes to life. But that is why I keep saying some of these skills, we need to develop some of these skills because we need to make a real impact in the life. Believe me, there is no decision when it comes to decision, patient care, that somebody will now sideline physio and say physio. No, it doesn't happen. So we need to be up to that level for us to be, all these things, they need to be at our fingertips. Anyways, let's move forward. So considerations again, if you need to win somebody on oxygen, do you even know their target? It will be very silly of me as a physio. I am winning patient oxygen. And somebody I don't even know, maybe they are meant to be on 88%, 88 to 92 target. I mean, they are, let's say they are now on, let's say my patient is now on 80, let's say 83, for example, now. No, let's say 89 or 90. I mean, I am thinking, 89 is not up to this thing now. This patient should be on 95. Who told you? What if the patient is meant to be on scale 2? So you need to check those things before you think about getting the oxygen up or getting the oxygen down or even totally removing the oxygen. So you need to know their target SAT. Again, we are re-emphasizing that. It really makes sense to us. So, and again, of course, you can titrate up, you can remove it. These are just slides that are talking about what I've explained. Long-term oxygen therapy, I'm not going to talk about this here. I'll leave it aside. But this is just let us know that, again, we can have that difficult patient in the world that you tell your physios, doctors have done their own, everybody's doing their own, and the respiratory team, they've done their own. But this patient is not improving. But we've got a lot of patients like that now their baseline now for the rest of their life, it could be that they might be needing oxygen support at home. But the question here is, have we really got that support from the government to be discharging our patients home with oxygen? So that shows our health system, we are still crawling. Believe me, does it now mean generally in Nigeria we don't encounter this kind of patient that everybody will be struggling to wean them off oxygen, and they should be going on with oxygen. By the time we discharge them, they should be going. What really happens to this patient? Because for you to discharge somebody with oxygen, you need to teach them some certain things. You need to get them, because at some point the oxygen might be, they might be out of oxygen. Where do they refill the oxygen? All those things. So just look at it. What happened to this patient in the end? Patients that are meant to be going on with oxygen, now they are not going on with oxygen. We just look at, they are saturated for a while now. We just discharge them. But there are some clinicians that also know that this patient, they should be going on with oxygen. But because we don't have the resources, we just discharge them. And what happened to them in the end? This is what we need to keep opening our eyes. Because if we don't open our eyes, the government will not know all of these things. And if they don't know, that means there are a lot of needless death around this as well. There are a lot of needless death. Yeah, you find oxygen patient. In fact, you find some employees that will say, I only use my PRN oxygen. What's PRN? They just use it when they need it. When I want to wear clothes. Imagine silly things. I want to wear clothes. It's not silly now. I just get breathless. I really get hypoxemia when I want to wear clothes. Some will say, yeah, I can even still sleep, or I can still walk to my toilet. I will not disagree. It's only when I want to go to the bathroom, or it's only when I want to wear my clothes. And these people still live with oxygen at home. So, but how about patient? So we really need to keep opening our eyes. If we are, we need to keep talking about these things. We need government intervention in our health system. The reality is our health system is crawling. We need to get it. We need to really start thinking about how we need to be supporting our people. That is it. So I'm not going to talk about long-term oxygen therapy. Forget that for now. Just focus on the basic things that I've talked about. Yeah. So again, this is just like a breakdown of what we have been discussing about weaning, about titrating oxygen. We have mentioned that. I won't go through this as well. So now case presentations, ladies and gentlemen. Ladies and gentlemen, we've come to see patient on the wards now. So let's text what we have been saying. Let's text our clinical reasonings. And again, remember, we are not interested in if you are right or if you are wrong. We are just sharing knowledge, racking brain together. That's what we're doing here. So ladies and gentlemen, you've got 72-year-old gentleman. He's on your ward. He's hypertensive, poor sight. He's had a couple of falls. Difficult, hard of hearing, and they have previous stroke as well. A lot of comorbidities there. Okay. They were admitted with aspiration pneumonia, queried aspiration pneumonia. Maybe the medical team are still investigating that. So they are currently on 4 liters of O2 via nasal cannula, and their saturation is 91%. So what do you think as a physio? You are going to see this picture. Forget about chest treatment, or you can even still talk about that. Right? So anything, what do you think? This gentleman, 72, or forget about the, let's say, because 72 years, still, some of them can still, let's say 65 Nigerian context now, 50, 47 Nigerian context. Yeah. So what do we think about this gentleman? Yeah. Physios, please open your mic. What do we think? You've got a patient. You've got their past medical histories. They are saturating at 91 here. So what are your thoughts? Hello? It's time for me to hear you guys as well.
I think shouldn't he should start being weaned off the cannula slowly, off O2.
Okay.
Because since his oxygen saturation is currently at 91%. It's within range for people that's within range for people that are having respiratory failure, which is not exactly what he has, but he has a condition that would affect his breathing in some way.
Okay. So what condition are we looking at here? Am I affect his breathing?
The aspiration pneumonia.
Okay. Cool. Thank you for that contributions. Yeah. Cool. Yeah. Yeah, guys, please speak up. What do we think? This gentleman is your patient here. You've gone to see them, or your junior colleague just came back from the ward discussing this patient with you. What would be your input? Yeah, please, guys, open your mic. Please. I'm begging you guys, please talk. I'm also reading the chat, but I'd like us to speak up. Yeah? Hello? Hello? Oh. Guys, what do we think?
Sorry, I think, can you hear me?
Yeah.
Okay,
Go on.
so I want to know if this patient is actually breathing properly on this with this oxygen saturation. If they are breathing well at 91%, I want to know whether they're having labored breathing or increased work of breathing or something like that. Then, if they are, I'll probably want to titrate the oxygen level. I increase to maybe 5 liter or more.
Okay.
That's
Okay, thank you very much. Thank you, Peter Yinka, for your contribution. Thank you. Yeah, guys, let's pick up. At least I want to hear at least 3 more persons, because this thing is not as interesting as we discussing case. We bringing forward likely things we can be seeing on the world. Because if we don't talk these things, we just do the teaching and we'll go. Honestly, believe me, we've not learned anything. We need to speak, we need to talk. What do you make sense of everything I've been discussing? Then put that in the context of a patient. Now, this is just theoretical knowledge. Like I mentioned, you have not learned anything yet until you do the practical, until we see you doing it, until we see you having good clinical reasonings around these things. Because this is delicate drug. We don't want you to go on the ward, mess that with your patient, and it does not make sense. It does not make sense. Yeah. All right.
Okay, let me try, sir. Let me try.
Yes, ma, go on.
So in this 72-year-old man with history of hypertension, poor vision, so one of the things I'm looking at is the aspiration pneumonia, and is on 4 liter nasal cannula, making SpO2 of 91. So my main target would be to see if I can get increase the target SpO2 to above 94. Okay, because with 91, I mean, he's likely to be hypoxic. And then with the aspiration pneumonia, it's likely that this patient is retaining, likely having secretion retention. Okay, and then that could also result from the previous history of stroke, which is poor. He had maybe poor swallowing and a weak cough, which could increase the risk of aspiration.
Perfect. Yeah.
Okay, so my problem list here is the inadequate oxygenation, maybe return secretion, and a weak airway clearance, most likely, and then high risk of aspiration. So I will start by escalating oxygen.
Okay.
That's I can move from to face masks, which will give me a higher flow rate, okay, both 5 to 10 liters.
Perfect.
And I will also reassess, always important to reassess, to watch for this, if there's any change with whatever I have escalated to.
Yeah.
And also discuss with the medical team also. I know I'm qualified to do that, but I also discuss with them. And also consider the risk of aspiration also in terms of positioning in these patients. So positioning can also help. to maybe keep the patients in upright sitting and preventing non-flat supine positions in these patients. And then with the airway clearance, I could teach these patients some airway clearance techniques like supported huff or cough in this patient. That would be, and then probably early mobilization can also work in this kind of patients just to improve the ventilation.
Perfect.
As simple as a sit out of bed.
Oh, very
and
key.
probably that is it for now.
Yeah.
And also for the aspiration, I want to also work with the other medical team. I mean, I could also speak to speech therapists.
Cool.
Okay. Not in our setting anyway, but I'm talking from international perspective and see if they could support with the background of that the patient could have a difficulty in breathing, owing to the fact that the patient has CVA. That will be for now. Thank you.
Cool. Thank you very much. Thank you very much. Appreciate it. Yeah. Yeah. Two more persons. Yeah. Lovely contributions. Yeah. Very interesting. Yeah.
Okay. I just want to, can I say something?
Yes, ma. Go ahead.
Okay. And I just want to add to what she said. Then maybe I would also humidify the oxygen because of the aspiration, so that the patient will be able to expel whatever. That's what I wanted to add.
Oh, thank you very much. Yeah, thank you very much. Interesting humidification. Yeah, humidification, perfect. Yeah, cool. Yeah, one more on that. One more. Yeah, that is it. When we share knowledge, it makes a different perspective. People talk about this, talk about that. Yeah, it makes sense. It makes a whole lot of sense. Because likely, definitely, in an idea, definitely you will be involved in this patient. No way. This is your patient. You're going to see this patient. Yeah. So what are you thinking about for this patient? What are your thoughts? This is acute hospitals. Remember this patient, if you don't see them, if you guys and the MDTs are not doing the right thing for this patient, the oxygen requirement can keep jumping up. Keep jumping. The oxygen from 4, they can start going to 10, 15, blah, blah, blah. Before you know, if you are not doing the needful for them, for this gentleman here, if you are not doing the needful, before you know, they might even end up in ITU, they might even die. So that is why we need intervention. So what are you going to do now for this gentleman? What are you going to do, guy? What are you going to do? Yeah? Somebody is there. Yeah, open the mic, open it. Yeah? Hello, who is there? I need one more person, just one person. Hello? Yeah? Somebody have written in the chat box, immobilization after forming, patient is already at risk of complications. My concerns will be on SpO2. Yeah, perfect. No active mobilization until stabilized. PT at risk of seizure. I will go with positioning, ventilations, passive mobilizations, DVT, pressure also as a preventive to prevent complications. Somebody have written that. People are still struggling with network. Yeah, also people with discomfort nasal can go for mask. Inside irritation, that's perfect. Definitely in the ITU. Yeah. So let me just go to it. Since guys are not speaking again. For this patient, you're gonna be involved, like I mentioned. Look at this man's background. They've got CVA, they've got background CVA, hypertension, poor sight, hard of hearing, CVA. Now, number one thing you need to be worried in none of these things. If let's say you are being asked to draw your problem list, yeah, what are the problem lists? This patient is currently on 4 liters of oxygen. 4 liters. How many FiO2 is likely to be that? If you go back to our discussions, normally everybody breathes with 21% from the air. Normally, this man he normally breathes from the air. Now he's needing oxygen. That's a problem list. What is driving that oxygen? We need to think about that. Now again, this patient is needing 4 liters via nasal cannula. This patient is still not maintaining saturation. And again, how do I know that this patient is not maintaining saturation? I want you guys to please talk about that. that you're going to check with the medical team. You're going to check, even if they have not documented in their notes, you're going to go and ask them that what is the target saturation of this man. I know from the question we can have a clip, but you know your domain, know what you should be doing. Don't just make an assumption. Yeah, I can assume that it's going to be, but then have your clinical reasoning with and still ask them, oh, what is the target oxygen saturation? Let's say this is a call. One of those questions you want to ask them, if they say, yeah, it's on 4 liters, it's desaturating, it's on 91%, you want to ask them, what is the target sat? Before you mention to me that patient is not saturating, what is their target sat? If that makes sense, about that. Okay, and you have to do that. Now, again, so why is this patient not desaturating? I mean, why is this patient desaturating? Yeah, it could be because they got aspiration pneumonia, they are acquiring aspiration pneumonia. Meaning, if, of course, this question I've not said anything about scan. When you check their X-ray, you might see some opacity, some harshness around some part of their lungs. And again, if I really want to ask you, clinical reasoning stuff, now aspiration, what side of the lung is it going to be, right or left side? It's likely to be on the right side because of your bronchi, the way it is positioned. It's likely to be on there. These are clinical reasons. These are things you'll be able to, even while reading the notes, you can make some judgment, some assumption in your head. And again, that does not mean what you are assuming in your head is always 100%, but at least it's just clinical reasoning stuff now. And again, this patient, what is the greatest worry, your greatest worry in this patient? Oh, I'm talking about problem list, desaturation, no ventilation, no saturating well on 4 liters. And that problem list, maybe issue with secretion retention. It's another problem list. These are physio amendable stuff. These are stuff you need to treat this patient for. Yeah? So what do you want to do? Of course, before you start treating, check the respiratory, check every other thing before you start treating. But what are your greatest worry in this man? Desaturation. The desaturation is likely to get worse in this man. So what do you want to do? It depending on how my patient is presenting on bed. Yeah, some patients might be, they are now getting tired, they are this, they are that. I might want to just think, maybe first of all, think about, let me first blast them with oxygen first of all, then I can start doing some other stuff. It depends on your listening. I might just say, okay, let me blast them on, maybe, like somebody mentioned simple face mask. Yeah, I can go for that, 5 liters. Let's see what they are on 5 liters. Yeah, they've got aspiration pneumonia. That is going to affect their ventilation perfusion ratio. I'm not going to talk about that. Yeah, and again, what does that want to do with them? I can ask them, do your assessment, ask them to cough, if you need to yanker them, yanker, if you need to function them, get them out of that bed. Get them. See, what evidence actually suggests for patients that are like this is not to keep them in bed and start blowing, what is this thing again? Send this parameter, doing deep breathing exercises. If your patient can mobilize out of the bed, what evidence support is get them out of the bed. Sit them out in the chair. Pop them on 5 liters of nasal cannula or whatever distance or whatever oxygen you deem fit for your patient. Pop them out. Now, somebody had mentioned that they in the past medical history, they've had fall. This is not looking like a recent fall. It's looking like maybe fall they've had maybe last 6 months or last year, 2 years ago. But if it is a recent fall, as a physio, clinical reasoning, before you get them out of bed, you want to check with the scan, check with their scan. Generally, even if patient fall on the wall, generally as a physio, before you start doing stuff with them, see their scan. See if the doctors, they have also cleared them for you to get involved, for you to mobilize. Because if there is a fracture somewhere in the tibia, in the fibula, you want to mobilize the patient with that, your competency needs to be queried if you are doing that. So generally, you want to see patient after they have been cleared by the doctor if it is a new fall, before you see them. But now this is looking like past medical fall. I'm not concerned. Yeah, we know certain things are here that can make this patient fall. The poor sight, hearing problem. Don't forget your fall, like there are 3-legged stuff, perceptions, hearing, auditory, visual, stuff. All these things can make you fall. Yeah. So think about all of those things. But here, your major concern is the chest. Yeah, chest. But you can still use your mobility to boost their chest, because when you get them out of there, I talked about functional residual capacity that time. When you get them out of there, it increases their functional residual capacity, their tidal volume goes up. Before you know, their saturation gas getting better. Do your chest off, deep breathing, coughing, ACBT. If you need to escalate treatment and start treatment. But first of all, I address the hypoxemia. Now, let's say I'm doing my stuff, they are coughing, I'm even they are clearing, they are coughing stuff, I'm clearing stuff, they are avoiding, and their saturation is still going high. I want to, because I know if there is one thing that is going to kill this patient here, it's going to be oxygen. First of all, oxygen is likely to kill them first if you don't intervene, if you don't give them certain amount of oxygen. One thing that is likely to kill them first is likely to be oxygen. So now, somebody mentioned about speech and language. Yeah, these are stuff that we want them to be doing on the ward. Because somebody aspirating, do you want to start getting them to be drinking again so that water fluid can start going back down to their lungs? You need speech and language to come and do their swallowing test. They might say nay by mouth for a certain period of time. They might say these things can be on team fluid. Oh, these are people we need to be getting them to be working, to be supporting our people on the ward. That is why, again, somebody cannot just stand up today and say, yeah, I am the master in the healthcare. You cannot be the master. You can never be the master. So, but we need people to be trained, to be able to do their job. People, well-trained people to do their job, to be handling our people. Our people, the life of our people should be our priority as well. So this is what you're going to do for this patient anyways. Now, you've got another gentleman on another ward. You guys, your view again on this man because of time. You've got another person, 79 years, person on the ward. They are saturating at 98%. On 60%, their saturation is, hold on, I think there is a mistake here. Yeah, I think their saturation is 98% on 60 liters of humidified oxygen. That is the question. Sorry about that. 79-year-old man, their saturation is 98%. They are on 60 liter humidified oxygen. And again, they are admitted with shortness of breath. Their past medical history, they've got dementia, they've got hypertension, they've got asthma, OA, hip replacement as their past medical history. So what will you be doing with them? What do you think? They are on 98% and they are on 60 liters. Yeah. And now the first question, I forgot, somebody mentioned humidification. That's a very, very valid point. If somebody has got evidence of secretion retentions, we have to start thinking about, because they are still on nasal cannula. If I do my stuff and their oxygen requirement comes down and they are now saturating, I can just say to nurse, nebulizers. I think I explained that in the other time. But if I need to start escalating further on another oxygen device, and their saturation is not still meeting, and I can now start thinking about humidification, humidified oxygen, all those aqua pack, those things that I mentioned the other time. Please remember those things. So please, second questions, guys. What do we think? Second question. Please open your mic, please. I'm begging you. Open your mic. I can't do this thing alone. Open your mic. What do you think? Yeah. Second person, what do you think? This is another gentleman or lady now, this time around, another gentle lady. Yeah. So it's saturating at 98%. Okay. Yeah, go on.
My major concern here would be that this patient is over oxygen, is at risk of receiving more oxygen, because why 60% and the patient is saturating and requiring high FiO2, and the patient is still on is saturating at 98%. So the major challenge here is to reduce the oxygen, most importantly.
Yeah.
Because it seems that we are over treating. If like you said, weaning down, titrating on the oxygen and weaning down will be the first thing.
Yeah.
There.
Cool. So what are you thinking about in terms of winning now? What level, like 60 from 60% now? What level are you thinking about bringing it down? Don't forget, I talk about small. If you need to increase, small increment. If you need to decrease, like go stepwisely. So from 60 now, what level are you thinking about bringing them down to? Hello?
40.
Yeah, maybe 40. Thank you very much. Yeah, maybe. Yeah,
40.
cool. Yeah, cool. Thank you very much. Because you don't want to just, somebody on 60, normally we breathe with 21, but somebody is using 60%. 60%, normally every one of us, 21 from the atmosphere, but somebody is now using 60% to maintain 98. But you and I, we are using 21 to maintain 9800. Somebody is now using 60. You now want to start bringing them from 60 and bring them to 28. Hey, that's too huge. You don't want to do that. You want to go stepwisely. 60, let me bring it down to 45, 40, let me from 40, let me bring it in. Now, and again, from 60, from that 40 now, Let's say they're now on 40 now. They are still 98%. You can even, when you now even bring it out to, let's say 40, you can even find some patient 9800. So what do you want to do again from there? All these things is just for us to understand these things. Please, please speak, please.
You bring it down more.
Yeah.
So
To
like
what? Maybe from 40 to what?
To 20. You continue to reduce to 20.
Okay.
Down to 20.
Yeah. You can bring it from 60 to 40, from 40. You can still go stepwisely. You can do 35. From 35, you watch, you check, you watch for signs, you check your saturations. You can now, at some point, if you now say, let's say now from 35 now, I want to bring it down, maybe to 28, like you said, to 20 or whatever now, 28 now, for example. Now, and it's not like, oh, it's now dropping to 90. When I put it on 30, I now drop it to 90. Yeah, what am I going to do? I'm going to bring it back to 40, and I will keep them on 40. And what am I going to do? I'm going to document those things, what I did, what is their saturation when I was bringing the oxygen down. And I also inform the nurse to monitor them at the bedside. Does that make sense? Now, again, your physio stuff. Now, 60%. Let me say this. Let me just say clearly. You can do your stuff with them in bed, blast them with the standing chest, blast them with whatever you want to do, ACBT, self assist, everything you want to do with them, blast them. There's indication for that, no problem. Now, if you need to mobilize, I'm just concerned with mobility now, because now let's imagine this patient is on 60 and their saturation is, let's say 92. They are using 60% to maintain 92. And you're even thinking about from 92, because let's say their targets are says 95 now. Or let's say you are using 60 to maintain them on, let's say 94. And the medical team, their target sat is 94 to 98. Do you want to mobilize this patient? Physios, yeah, I didn't talk about that the other time. Do you want to mobilize this patient? Let me repeat my questions. Somebody is on 60 and their saturation is 94. Do you want to mobilize them? Physios, your patient, do you want to mobilize them? Just one person, speak. There's no right or wrong. Then we'll move forward. Please. Time is gone already, I know. Yeah, what do we think? Do you want to mobilize them? Somebody is using 60 to maintain, they have said the target sat is 94. Somebody is now using 60 to maintain 94. And you and I, we are using 21 to maintain 9800, 9700. Do you want to mobilize them?
I won't be, not immediately. I won't be, because this patient is requiring high FiO2 and still maintaining 94.
Yeah.
I would consider, I'll be so cautious.
Okay.
Before mobilizing them, because they're requiring high FiO2.
Yeah.
They require high oxygen demand.
Yeah. That is just the point I want to hear. Just always remember this thing. Somebody is on, we breathe with 21. Somebody is now needing 60. 60 is huge. To maintain the lower range of their target. Oh, you want to think about physios? Yeah. That does not mean you cannot get them up as a physios. Yeah. You do your risk and benefit. Why you have to be very clear. Why do you want to do that if you really need to do that? And sometimes if you look at it, your patient, this patient is likely to desaturate, because by the time you mobilize them, their sat is likely to drop. The chance is there because the oxygen requirement in the body will go high. Their chance is likely, the chance is there that they're likely to desaturate. What do you want to do as a physio? You can say, okay, if they are likely to desaturate, I can even pre-oxygenate them. That is the terminology we use. You can even pre-oxygenate. I can just top up the oxygen. Yeah. By the time you top up, by the time they're going to desaturate, they're going to still be within range. That is what it means. You can still do it if you want to do it. And that does not mean every 60%, somebody using 60 to maintain 94, we must always desaturate when you move them. That does not still mean that again. If that makes sense, that does not still mean they must, but you have to put that in the context of your patient. But again, this is not the decision you want junior colleague to be championing, to be on intense, to go on the ward and see somebody on 60 and say, yeah, I'm going to move you. And you are using 60 to maintain lower target. And yeah, I'm going to move you. Please don't do that. These are stuff we need senior physios to be doing. Because moving patient in that, honestly, that simple movement that you are doing for that patient, it might likely be the greatest things that will make the greatest impact in the life of that particular person. That is why in acute hospitals, acute settings, your skill set, your knowledge, looking at your patient and make good, great decision for them is very, very good. It's very impactful. But I can make a huge decision for them. So, and again, what I'm going to say is generally oxygen-wise, in terms of mobility, keep it low. Maybe junior colleague, I would say less than 35. Just keep it less than 35. Less than 35. Juniors, senior can still do 40, can still do 60. But look at your patient, look at what they. And again, if you need to move them, you can do gradual mobility. Maybe from lying, you can do sitting. Get them to sit. I have told you, evidence does not. Even when it comes to patient care, when it comes to ventilation perfusion matching. Somebody lying in bed and you're asking them to be blowing whistle, blowing in central spirometer. It's not even the latest things. Think about moving them out of that bed. Now and again, if they are very poorly on the bed, they cannot even tolerate sitting. They cannot. Now we know that we cannot think about okay. What can we give them? What can we ask them to do in bed? But it should always be at the back of your mind. It's until you move that patient that you can say you are successful as a physician, not when they are in bed. Just do whatever you can do with them. If let's say by chance you cannot even move them because they are very, very poorly, a lot is going on with them at the moment. Yeah, support them in bed. Think about everything you can support them with in terms of your treatment approach in bed. But your target will be how we can move this patient from lying to sitting. It might be a stepwise approach, lying to sitting, assistance of 2. When you are doing that, you are getting somebody upright. You are increasing their functional residual capacity. You are strengthening them. You are strengthening their respiratory system. Because we want to start winning those gadgets we are using to those those treatment, advanced treatment we are using to support them, like cough assist, IPPB, to give them bigger breath, bigger tidal volume. We want to start winning those things for them to be able to cough by themselves, to be able to manage their airway, to be able to mobilize. We want to win down the oxygen. You have to start getting them active, getting your patients, getting them into active treatment rather than passive. If that makes sense to somebody. So that does not mean you cannot still support your patient with spirometer. You can do, but normally it's not routine, something that I routinely want to even think about when it comes to patient care. My patient can do deep breathing exercises. My patient is standing, walking, sitting out in my. Why am I giving them the spirometer? I know from visual point of view, when they look at it, they can keep blowing. If your patient, just tell them, be doing hourly deep breathing, because what evidence says is by the time you ask them to do hourly breathing, it takes maybe 1 hour or so for alveoli to keep recruiting and to keep repeating. So just get them, do deep breathing, mobilize them, and your patient will be fine. It's as simple as that. So I'm only telling you these things in terms of mobility. Look at the oxygen requirements. If the oxygen, of course, if it is greater than 60, 70, they are likely to be in the ITU. I swear. If they are in ITU, if you really need to do any mobility there, it has to be done by. We're going to talk about those things later on. Don't let us drag down on that here now. So think about those things. I think I still got maybe 1 more or 2 more case study to talk about before we go. I don't know, no way. I'm going hypoglycemic already, so I won't be able to run, and time has gone already. I won't be able to run the blood gas today again. This is another patient. Guys, please, let's just finish these things and let's go. 86. Why am I bringing big years now? Let's say 55-year-old man, and they are admitted to the ward. Let me drag this one up. They are admitted to the ward. They've already spent 5 days already. When you check their SAT, they are on 84 on room here. What do you do? What do you do? I think this thing should be making sense to us gradually now. So what do you do? This is another patient now. They spent 5 days on the ward already, and their saturation is and they are only saturating at 84%, and they are on room here. Room here is, they are not on any oxygen device. So what do you think? Are they maintaining their SAT? Do we need to supporting them? Do we even know? So what do you think, guys? These are live cases, something you are likely to see on your ward. So what do you think? Please talk, guys. Please. Let me check the chat box.
Okay.
Oh, somebody said I'm still confused about saturating and desaturation. Saturation is you have good numbers of oxygen on your blood. If I put oxygen, what's it called now? Pulse oximeter on your finger, and your SpO2 says 98, it means you are saturated. You have good numbers of oxygen on your hemoglobin. Saturating is your oxygen on the hemoglobin is coming down. Let's say the doctor have mentioned that we want our oxygen on hemoglobin to be between 88 to 92. And you are now 87, you are 85, 96, you are 79. Or let's say they have mentioned between scale 1 now, greater than 95, it could be 95 to 100, and somebody is now 91, 89. That is when you are desaturating, if that makes sense. Yeah, mobility is top notch. Yeah, anything acute physio, what you are doing, your greatest goal is mobilizing patients. Mobility does a lot of stuff. It should not be underestimated. Yeah, please speak up if you need to speak. We've got a case, we've got a patient in front of us. What are you going to do with them? We're going to leave them? We're going to run away? Yeah, time is going. Please speak, somebody. What are you going to do? Are you going to run away? Are you going to leave them?
Okay, I want to know what is driving their saturation to be that low.
Okay.
And then I will also escalate. I will escalate it and put them on NASA prong and see if their saturation improves or not. I also want to know what their target saturation is supposed to be, to know what's the range I'm supposed to look at.
Okay. Okay, good contribution. Thank you very much. Yeah. So what are you going to do, guys? Yeah, let's get two or one more person. Yeah.
Okay, so for this case, I mean, it's an emergency, and I would apply the ABCDE approach of the examination.
Okay.
So can you hear me?
Yeah, audibly, yeah.
And 84% is showing severe hypoxemia. So with the assessment, I would escalate immediately, call the attention of the medical team for rapid response, and consider putting this patient on O2 support.
Okay. What support are you thinking about? What oxygen support?
I'll start off with nasal cannula.
Yeah.
And see if it works for the patient, and probably escalates to a more higher oxygen support if need be.
Yeah, good. That's it. Yeah, cool, perfect, good answers. Of course, again, if I know their target sat, that will be fine. Of course, and again, I need to act. Yeah, I'm not going to leave this patient unattended to. I'm going to act. Yeah, of course, if you are not competent, give the nursing staff, give them a shout. Oh yeah, we've got somebody is desaturating. Yeah, they might come around. Oh, this are also. And again, are we even sure? Again, that's another thing I didn't mention that. Hey, but if you pop somebody will go cold hands now. Do you want to try and fix different fingers? Do you want to look at the trace? These are something we should be able to figure out as a physio. Look at the trace of the oxygen. Is it poor trace? If it's a poor trace, do you want to try it on the hair before you make some certain decision as well? You want to think about that as well. So now, so what you want to do, like you mentioned, you can start them on 1 nasal, 2 nasal, 3 nasal. If it works for them, you might escalate to other oxygen devices. As simple as that. It's just to get our what do you think? But again, know their oxygen tags, know what we are aiming at. Because if this patient is on scale 1 now, scale 2, 88 to 92, and you are aiming for 95, you might be doing the wrong thing for the patient. It's as simple as that. Last question for today. You've got Mr. X is on your ward. He's been diagnosed by the medical team with lower respiratory tract infections. So they've been on 60% Venturi for last 2 days. They are saturating at 94, 95. You have tried to win his oxygen down to 40. However, every time you do this, Mr. X desaturates to 89. He has no background of COPD. He has no lung conditions. So what will you do? What are you going to do? Anytime you try to bring their oxygen down to 40, their SpO2 89%. So what are you going to do? Physios, what are you going to do? These are life things. This is what you will see with patients. You will see this. Acute, you will see this. So what are you going to do with them? All right. What are you going to do, guys? before we close for the day, let me look at chat box. Yeah, unity here. Please talk. What are we going to do for this patient? Let's get a response before we go.
Okay, let me try.
Go ahead.
Okay, this your patient has no issue of COPD. So them saturating at 89 is not adequate, is not something that should be maintained. And now they are maintaining 94, at 5 at 60%. I'll want to conduct my ABCD assessment to determine if there is any chest secretion. There's any secretion, I'll want to work on that, check their positioning, and if all of that fails and their saturation is not improving, well, if all of that fails, I don't know, escalate.
Okay, cool. Thank you very much. Thank you for that. Yeah, good contribution. Yeah, good assessment, A2E assessment, checking everything. Yeah, good. And if you do your physio stuff, it's not working, you escalate. Good, cool. Yeah, let's get another perspective. What do you think, guys? What are you gonna do with them? Guys, what are you gonna do?
Okay, so let me try something. So I see that, let me come to that, well, ask what she said. So if I'm winning and I see that this shows that this patient is not ready to win yet, it means that patient still has an impaired oxygenation and are still FiO2 dependent. So I won't be so quick to, and since the patient drops while I try to win, I won't be so quick on winning these patients. I will try returning the patient to previous safe oxygen level, and then try also airway clearance to see if there's any retained secretions causing this, or is it based on this ventilation perfusion mismatch regarding what the patient is not agreeing to win. Then I will take it from there.
Yeah, cool. Thank you very much. That's a nice contributions. Of course, it could be like you mentioned, it could be that your patient is still not ready to win. So it could be that now you start thinking about your treatment approach. Are they still, struggling with secretion burdens? Are they thinking about all of those things? Or could it be that you might need to start retraining them, rehabbing them? By the time you rehabbing them, what you are doing is you are trying to train their what's it called now, resilience. You are trying to train their body to be able to use the oxygen better. It could be because it's just you. There's no way, no single way to these things. It's all about you thinking about how best can you support their chest. It's all about you thinking about how best can you supporting them, keep supporting them as a whole. And again, don't forget again, one thing here is this patient is on a ventilator mask. This patient is on a ventilator, and you've been struggling for the past 2 days to win them. And now we are talking about, could it be from chest point of view that is driving their VQ matching, that's making it to be wayward and something like that. So are we thinking about, first of all, escalating them on humidified, give them humidified oxygen, moisturize their airway now, and again doing your chest physios, and again rehabbing them as well. So it's just we thinking far and wide for our patient and supporting them with whatever things they need. And again, if your patient is desaturating, you keep changing and changing, they keep coming to it. You don't want to force that. You don't want to say today you must be on 40 today. If your patient is still not ready, you keep them on the safe things, because again, it's going to be very, very somebody who is going to look like a criminal if you are doing that, but making that decision. You are forcing your patient. They are not yet ready for 40, and you are forcing that 40 on them, and they are now you now leave them on 18 and say, yeah, I'm going to see what is going to happen. What you are doing now is you are gradually withdrawing life from somebody. Please think about that. So I'm going to end here today. So the summary of everything I have mentioned is, please before we go on the ward, before we start managing or before we start maneuvering oxygen, we need to sign competencies on it. We need to be able to demonstrate that we know it, we can do it, we have handled it before we do all of those things. Don't joke with it. It's very essential tools in life and in supporting our patient as well. And again, if we need to be doing something, if we are not doing it, we are not doing our best for our patient, we are not delivering that harm-free care. If we are not meant to be doing something, you are doing it, you are not doing well for your patient. Think about that. And again, regarding oxygen choice, you've got your nasal cannula 1 to 4. For 1 to 4, you can mobilize the patient. If every other things are fine, you can win it, you can titrate it down, all those things. Simple face mask, you can work from 5 to 10. You don't want to try that with patients that are maybe risk of retaining CO2. And again, venturi mask is there as well. We have talked about how you can swap between venturi, low supporting FiO2 on venturi to nasal cannula. We have talked about that, the reasons you can think about that. We have talked about humidified oxygen. If there is evidence of secretions, you can talk about humidification. And in the case of emergency, we have talked about non-rebreathe. You can support your patient with it. And maybe on the ward, the highest we want to go is maybe non-rebreathe. And if we need to go further than that, higher than 15 liters, we want to be thinking about maybe in ITU or something, or maybe patient might be needing an IV or CPAP or something. We're not going to talk about those ones here. So think about those things. So so what we are saying in the real sense of everything is physios, we should be involved in all of these things for our patient, because these are acutely ill patients, and if that are needing high amount of oxygen to support to live. And if we are not doing our stuff with them, it could also be that it is that our stuff, that simple stuff that we're going to do with them, that's going to make a big impact in their life. So let's learn all these things. Let's keep learning. And please, questions before we go, because I'm already at the assignment. So let's take questions. The moderator, is anyone still here? Moderator, who is still here? Moderator, sir, let's end today's teaching here. So let's take questions. I'm happy to take questions before we go. Questions, contribution, reflections, what you have picked up, what you think is going to be a challenge, where you work. So just discuss.
Hello.
Hello, sir. Hello, ma.
Hello. Hello, sir.
Hello, ma.
Sir, are you done?
Yeah, I'm done. I'm done, sir.
Are you done, sir?
Yes, sir. Yes, sir.
Okay, thank you very much, sir. We really appreciate it, sir. I don't know if there is any question from the audience, from the participants. Is there any question, please? Question, comments, or you want to shed more light about something? So you are free to do so. Thank you very much, sir. Is there any question?
Yes, please, sorry. I need clarification on something.
Hello.
Yeah, go ahead.
Okay, you can go ahead.
Oh, yes. Please, you talked about...
Yeah, go ahead. Go ahead and ask your question.
Yes, sir. You talked about water vapor in oxygen tube. I didn't really understand what you said in that part. You were talking about water vapor, that 1 liter, something. I didn't really understand that part.
Okay. Yeah, what I was saying is our tubing, if you look at the screen now, if you can see my these things, let's say this is of course, it's going to be for aqua park now, it's going to be elephant tube, like those ones that are bigger than this, elephant, big animal. So those ones bigger than this. So now, so we want to keep the tube as small as possible to the patient. Because if it's getting too long, again, think about what is going to take oxygen to move from this lung to get to your patient. Think about that. And again, because of that, because the oxygen you are giving them, if it is humidified, it's not just dry oxygen that will just go down. It's just mixture of oxygen and water. So at some point you might find some water condensed in the tube like this. You can find that. So what do you want to do? It's all about you maybe draining the water, or if you are thinking that the tube is too long, I might swap it to a smaller length. It could be maybe 1 meter, something like that. or less than that, if depending on where the oxygen source is. Or again, if you need, sometimes I just go there, I just look at, this is a long one. Just if I can't find a small, I can just cut it. I just take a scissors, cut it. It might be as simple as that. So that's what I'm saying. Because so your tube that is meant to be free, you are now having water inside, and another concentration of oxygen is coming, it's going to get mixed, and again, it's not going to be effective for your patient. So I don't know if that answers your question.
It did. Thank you. It did.
All right. Yeah. Thank you very much. Yeah. Questions, please, guys. So before we go again, I want to encourage us, please, we've got the WhatsApp page, pop your questions there, write your reflections, send it to the page. You don't have to put your name or something, just put, like, reflection is very, very important. Put your feedback there. What do you think? So all those things, please, let's get feedback. It's very, very important. And if there are questions, I'm also on the page. I'm happy. I'm more than happy to attend to those questions. Thank you very much. Moderator, I don't think there are other questions. I don't think guys are.
Okay, sir. I don't know whether the registrar has something to say.
Yeah.
The registrar, sir. So maybe the registrar is not with us. Okay. So in the absence of question or comment, we'll call it a day. Thank you very much, sir. We really appreciate your time, despite your tight schedule. You spare your time to enlighten us about so many things. We are very, very much grateful, sir. Thank you very much, sir. So we'll see you next time. Bye bye.
All right. Thank you, everyone. Bye.
Thank you so much. Appreciate. Bye.
Bye, sir.
Thank you so much. We really appreciate.
Thank you very much, sir.
Bye-bye, Rita.
Thank you so much. We really appreciate
it. Bye.
Hindi magana na interview.
Thank you very much.